Welcome to the Humber Teaching NHS Foundation Trust meeting. Streaming into us today. So starting the meeting, have we got any apologies for absence? No, I don't think so. I haven't received any. No. Declarations of interest. If anybody's got any declarations they need to declare or there's any changes, please let the Trust Secretary know. And of course, if there's any item on the agenda that provides any conflict, please say so you can remove yourself for that item. Are there anybody in that situation today? No. Great, thank you. So we'll move on to the minutes of the meeting held on March the 30th. Can I just see if there are any corrections to those minutes, please? No, I can't see anybody. Thank you very much. So can we receive and approve those minutes? Yep, thank you very much. That's approved. And we'll move on to action log and any matters arising. Is there anything anybody wants to say on the action log, please? No? OK. Can we receive those for the record? Yep, that's great. Fine. Thank you very much. And now I'm really pleased we're going to move on to our staff story, and we have Sadie Milner with us today. Welcome, Sadie. Good to have you with us. And Hilary, are you going to do a little introduction before we pass on to Sadie?
Thanks, I will do. Thank you, Caroline.
Thanks, Hilary.
So yes, welcome, Sadie. Sadie's here to do the staff story around patient safety in the trust. This is at the request of the Quality Committee. We had quite a few papers at the November Quality Committee around patient safety, and the committee wanted something at the board around a staff story really that describes patient safety in the trust. So Sadie got the job ticket for her sins, but I know she's really looking forward to speaking to us all this morning about her role at the trust. So without any further ado, I'm going to hand over to Sadie. Welcome, Sadie.
Lovely. Thank you, Hilary. Thank you, Chair, and hello to everybody. Nice to see you all. So I was invited to come along and give my staff story a couple of months ago, and I've given this quite some considerable thought since. I thought about the different ways in which I could present this. I didn't really want to do a formal presentation, but I have spent some time actually writing my story. So if you don't mind, I'd like to read that to you. So it is a little bit scripted, but I just wanted to make sure that I covered all the points. I've got quite a lot to say. I'm very passionate about what I do. So I hope you enjoy listening to it. So I am Sadie Milner. I'm the Quality Standards Practice Development Nurse working in the Nursing Directorates in the Quality Governance and Patient Safety team. So whilst preparing for today and thinking about my journey within patient safety, it's been a real opportunity for me to reflect with quite a lot of pride, really, as I celebrate 25 continuing service within the NHS. So my journey began back in 1994 as a student nurse at the Humberside College of Health, and it was part of what was then the new Project 2000. I lived in the nursing accommodation in the grounds of Delapole Hospital, Coniston House, which is now our trust headquarters. So when I came back to work for Humber and began working from Trust HQ, it did feel very much like I'd come home. So I qualified as a registered nurse in March 1997 and started my first post as a D-grade staff nurse working on Harvey Ward at Princess Royal Hospital in Hull. I'd enjoyed 2 placements there as a student nurse, and it was this early positive learning experience that led me to spend the next 20 years working for what is now Hull University Teaching Hospitals, where I specialised in oncology and haematology. So throughout my years as a registered nurse, patient safety has always been very much at the heart of everything I do. So, for example, when I was a chemotherapy nurse working in a nurse-led clinic, I would ensure patient-centred care was safely delivered against national treatment protocols, responding quickly to adverse incidents. As a research nurse, often delivering quite novel agents, I would ensure patients were closely monitored for immediate, short-term and longer-term side effects. As a transplant specialist nurse, caring for patients who, due to high-dose chemotherapy, they were at considerable risk of infection, neutropenic sepsis, and poor nutritional status. And then my last post at Huff was as an acute oncology nurse practitioner, where I had to ensure the timely and accurate assessment of patients presenting with treatment side effects and oncological emergencies, and had to be able to recognise and respond to sometimes very subtle changes in clinical presentation. So working within oncology and haematology, I was really privileged to be able to support and care for patients at their most vulnerable, whether that be during active or palliative treatment, during periods of remission, and often at end of life. And I'm sure all of you will agree, my nursing, medical and allied health professional colleagues, that patient safety really is the bedrock, no matter what your specialty. So during my time at Huff, I was really lucky to be supported to complete my specialist degree in cancer care. And then I went on to successfully complete my MSc in leadership and health and social care. And after completing my master's in 2016, I recognised I'd gained some additional skills and knowledge, which would enable me to influence patient safety in a much broader sense. And I was keen to take on a more senior leadership role, and that's what led me to Humber. I joined the Quality Governance and Patient Safety team back in 2017 as the Patient Safety Lead, which was a new role back then. Due to my experience from 20 years in the acute services as a registered nurse, I was very much able to bring my physical health knowledge and clinical skills to the table, instrumental in guiding the physical health agenda here at Humber ever since. I'm the Deputy Chair of the Physical Health and Medical Devices Group, which is a subgroup of QPAS. Physical Health and Medical Devices Group are responsible for ensuring safe systems and processes are in place in relation to physical health care. We oversee the review of clinical policies and approve clinical procedures, protocols and guidelines, ensuring they are based on current best practice. We're also responsible for overseeing the procurement and approval of medical devices and the implementation of actions in response to national patient safety alerts, medical device alerts and field safety notices. I've supported and promoted the work of the Patient Safety Collaborative on the deteriorating patient workstream, sharing Humber's experience of the rollout of News 2 with regional colleagues. Humber was a very early adopter of the News 2 tool outside the acute sector and one of the first multi-specialty organisations to fully embed the use of this national early warning score. I'm incredibly proud of the work I've led in relation to the Trust Zero events. As part of Humber's continued drive to minimise patient harm in line with the Trust's patient safety strategy, focus is given to a number of key performance indicators on areas of potential harm. These indicators have been called zero events as they should never occur within our trust. Zero events are determined by our trust and arise from a result of a cluster of incidents or emerging themes from reviews or investigations. They can also be driven by national guidance or findings from clinical audits. I'm particularly proud of the work in relation to reducing avoidable harm relating to pressure ulcers, deteriorating patients and falls prevention. I've supported and led on numerous serious incident investigations and SEAs, initially as a support investigator and then following a period of training, I became a lead investigator and I'm now an SI buddy supporting others. In my role as Quality Standard Practice Development Nurse, I contribute and lead on many of the same work streams. However, in addition, I've added clinical policy management, clinical audits, peer reviews, implementation of quality standards and practice development to my key responsibilities, all of which positively impact patient safety across the organisation. I actively contribute to the key deliverables of QPAS and the Audit and Effectiveness Group, providing issues, record-keeping audits and zero events. So one of my most memorable times with Humber, and one of the things I'm most proud of, has to be working alongside my mental health colleagues at Millview Court, leading the Rapid Response COVID team, supporting the development of the COVID pathway, developing and working at pace to produce staff through procedures reflecting national standards around the recognition and escalation of deteriorating patients. This was already well embedded. I'm particularly proud to have been there at the conception of the corporate safety huddle. Initially, it was just a few of us tucked away in a back office, but the huddle is now responsible for reviewing all patient safety incidents reported in the previous 24-hour period and ensures that the initial patient safety concerns have been adequately addressed, that the correct level of harm has been attributed, that duty of candour has been carried out, and that any potential omissions or lapses in care are swiftly and appropriately reviewed and escalated. Safety huddle, it's gone from strength to strength, and now representation and engagement from across the organisation, reviewing and all our patient incidents daily, Monday to We actively encourage participation from across our services and divisions, and this also now includes our students. It promotes multidisciplinary working. It's an open and safe space to ask questions, to raise professional curiosity and give professional challenge. I believe the huddle has been pivotal in us understanding as an organisation many of our patient safety risks, and using this insight has given us the ability to proactively drive improvement and reduce avoidable harm, and this is something I am and we are as a team very proud of. Due to the success of the corporate safety huddle, the divisions have adopted similar models and all divisions now have safety huddles. So when thinking about what's been most challenging, and I'm sure you'll all agree the past 2 years has certainly been the most challenging in terms of anticipating working through and living through a pandemic. But for as many challenges as it has presented us with, it has also brought about some real positive change. For me personally, working from home was challenging, but it's reaped many rewards. I feel better connected to my colleagues across all the divisions and services through MS Teams. I'm able to work much more collaboratively and engage with many more people. Whilst a large proportion of my working week is working from home, I still have the opportunity to directly engage with my colleagues face to face. I enjoy undertaking peer reviews, which means I get to visit clinical teams and talk to staff and service users about their experiences and can share and celebrate good practice. I'm looking forward to growing and learning with my nursing colleagues across the organisation as we take forward the newly established Professional Nurses Forum. I'm looking forward to working with my colleagues in the patient safety team as we co-produce the new patient safety strategy with our stakeholders. I'm looking forward to the rollout of the new patient safety incident response framework as we continue to embed a safety culture where staff feel psychologically safe to have open and honest conversations, and where our systems and processes support us in the delivery of safe care. My role in patient safety has changed significantly over the past 5 years. Initially, it felt very transactional in terms of reviewing incidents when things went wrong, and often felt rather reactionary. There was very much more a top-down approach, whereas now there's a real sense of engagement, distributed leadership, with much more effective communication and cooperation, working with and alongside our colleagues to share learning and embed change. I'm really grateful for the opportunity that Humber has given me over the past 5 years. I believe my skills and strengths and attributes are recognised, and through this I've had the opportunity to shape my role. I was part of a team 5 years ago, but now I lead a small team of clinical and non-clinical staff, and our team continues to grow and evolve. I'm lucky that I work with an amazing group of people, and I genuinely do feel very supported by my senior leadership team and my Executive Director of Nursing. I'm really passionate about my role in patient safety and the measurable positive impact it has. I would never have imagined being in such a role when I started my career 25 years ago. Nursing for me has been an incredible journey and has presented me with so many opportunities. Thank you.
Thanks very much, Sadie, for sharing your story with us today and give us a bit more insight into your work and how it sort of cascades throughout the whole organisation. So we'll have some questions, I'm sure some comments from some of our colleagues, but thank you very much. Mike.
Sadie, wow, thanks. That was really inspirational. Thanks so much for the preparation that you put in. You said it was scripted, and it was, but it covered so many points. And how many times have we done a little presentation, or we're going to say something, and then you get to your front door at night and think, oh, I've forgotten about such and such. So you've given us loads and loads of things that you're proud of, which is excellent, and you should be proud. You've given us lots and lots about work in progress, but what is it that makes you lay awake at night and worry about?
Thank you for that question. Right, okay, so if I'm brutally honest, I'll say probably nothing keeps me awake at night, and that's not a bad thing, really. I am assured that we've got really good systems in process. We have a really good reporting culture. we're not an outlier, but we certainly have that culture where we report our incidents, and generally low harm incidents, and we're getting very good at reporting our near misses as well. I think we've got really good systems in place for understanding our risk, for escalating our risk, and certainly Hilary and John's door are always very much open to me. So I don't lay awake in that sense at all. I do have things that concern me, and I think they're the things that concern most of us. In terms of patient safety around workforce moving forward, that's obviously something that the Trust is giving a lot of consideration to at the moment. But yeah, so that would be my answer. I woke up quite early this morning, but I think that was because anticipation of coming and speaking to you today, but certainly not sleepless nights.
Thanks, Sadie.
Good to hear, Sadie. I've got Dean and Stuart next, and then Dean.
Hi, morning, Sadie. I'm glad to hear you sleep well. That's very good to hear. I was really intrigued in your kind of life story about your recent reflections on the benefits of that enforced remote working has brought. And I wonder if you could just tell me a bit more about your reflections on how the fact that you're not seeing people kind of physically is nevertheless kind of compensated by able to talk to them kind of online and on screen and so forth. And just tell me about how you think that trend is. Do you think it's a permanent feature? Is it something that will eventually wane, or what? What's your thinking?
I think when it became very apparent that this would be a longer term, hybrid working, I did struggle with that a little bit, because I am a people person. I like contact with people. We all do. We all struggled during lockdown, didn't we, with the enforced separation from people. So to think of that as a long-term sort of moving forward, that was quite a struggle to start off with. But the Trust has been really good in providing us with what we need, the IT. We've really ramped all that up, haven't we? I'm in daily contact with my team. We speak regularly. We meet up at Trust headquarters. We make good use of the space there when we need to, and we meet socially up at Costa Coffee up at Willoughby. So we do keep very connected. And like I say, before all of this, when we had to have meetings, we were not able to connect with our colleagues up at Whitby and Malton quite as easily. So it really has, it's changed that for the better. Moving forward, I'll be sorry to see Trust headquarters go. That again will be a new way of working when we go over to the new, well, it's not Trust headquarters, is it? We're not calling it that, but so yeah, we'll see how that goes, won't we? We'll see how that goes. It's strange for a clinician, I suppose, somebody who's spent 20 years with that face-to-face contact with your patients and your service users and your colleagues, but it's got a lot of personal advantages for me as well. I'm a mum, I've got a young boy, I can do the school run, I'm always on hand, so I don't have the commute to work anymore, saving money on petrol. So there's lots of little things that make it positive, and it's about drawing on the positives into it and not. That's really interesting,
and I guess that's very interesting. I guess the art, isn't it, of modern living and working is to make the best of the technology without jettisoning all the things that are important about face-to-face contact and that human interaction. So thank you for that.
Can I just, before I bring Francis, just check something with you, Sadie? But seeing people in person is still important, and I just wanted to ask about how often you manage to get out and actually see patients or hear from their families, because they're part of the patient safety aspect of all this, not just staff.
Very much so. So at the moment, I get quite involved in I really enjoy the peer review process, because that allows me to do that. But we've got the option to do that both remotely and face to face. So it depends what the service is, where it is, how easy it is to get to, I suppose. But also we're still having to consider social distancing in some respects, aren't we? So it does still impact on my ability to get out. Like I say, majority of my working week is working from home. I do try and make sure that we meet as a team frequently. So I think my avenue into clinical teams is through when we're doing work around competency assessments, when we're doing work around if there's been an incident, if I'm leading on an investigation, obviously I go and meet the team and the staff face to face and speak to patients that way. But yeah, the peer review stuff is my avenue at the moment, very much so.
Okay, thanks very much. Francis.
Thanks. Hi, Sadie. I've had most of the question answered because it was the same as Stuart and Caroline. But the addition to that was, do you think the new way of working has created any new safety issues as a result of this kind of hybrid working, and that you needed to tackle and need to think about going forward?
Again, something I think we're all very aware of is the element around closed cultures, isn't it? And I think that was potentially a patient safety concern, particularly when we were very much in lockdown and we were not able to go out to clinical areas quite as much. That's probably lessened considerably now, but I do think it's quite important, isn't it, that we're quite visible and present in order to sort of make sure we haven't got any issues around closed cultures. So that would be my answer to that, I think.
Okay, thanks.
Okay, anybody else got a comment or question for Sadie? Michelle.
Yeah, thanks, Sadie. And it didn't come across scripted either, so thank you for that. And I know I agree with what Mike said, that sometimes you just need to make sure you get all the key points in. So, but it came across really, really good. And thank you. What an authentic, I think Dean's written that one, authentic presentation. It was a great way to start the board as well, because obviously we do patient stories a lot, but it's really good to hear from staff. I just wanted to say, first of all, very well done on what an absolutely journey. And I think that's really good that we need to keep publicising that for the whole of the organisation. So thank you for that. And just to say about the safety huddles, we know that that they've been award winning, but it actually was picked up, that and the clinical risk group, in relationship to our recent well-led, and we're going to come on to that. So I think there's a bit of a thread there, and I think that's really important. And Lynn's popped something in the message box about it being embedded. I suppose the most interesting thing for me that you've mentioned, the thing we're working and continue to work really hard on, and does link in with John's comment about the staff survey, is that distributed leadership piece, because we can be as visible as anything and be there all the time, but the close culture work and the patient safety is the way that we distribute that responsibility, accountability across the organisation, and it takes people like yourself, Sadie, to do that. So thank you for that. And it was really good and that resonated with me, because I think that's the real important piece for us. So thank you for that, but great way to start the board and fantastic work. Please keep it up. So interested to hear. So thank you. Really making a difference. Thank you.
Thank you.
Thanks very much, Sadie. I can't see anybody else. Thank you for your time this morning. I'm glad you said you were at the Costa Coffee and not the Burger King close to the HQ. No, we'll pass on.
Other coffee shops are available.
Yeah, I mean, I don't know whether Michelle and the EMT are planning our own coffee shop inside the hub or what have you, but it's interesting about how you do get this match blend together. But thank you so much for your time this morning, and maybe we can hear from you again at some point in the future, and some of your team. That would be great. Thank you.
Thank you so much.
Thanks, Sadie. Great. Okay. So the next item on the agenda, and thanks Hilary for making that happen and bringing Sadie to us for today. That was great. So the next item on the agenda is the National Staff Survey results, and we've got a presentation by Charlie Boscher from Quality Health. Is Charlie with us?
He's joining us at 10, Caroline. So
oh, sorry. Oh, right. Okay.
We're ahead of schedule. So whether you want to pick one more item up, and I'm sure he'll be with us.
Okay. Should we go on then to the external review of governance, and we'll pop back to Charlie when we've completed that item. Okay. Over to you, Michelle.
Okay, I shall be very quick, but I'm not sure I can do it in 5 minutes, Chair, but I will absolutely give it a go. Here we go. Obviously, everybody's seen the paper, so I'm not going to go through the paper because there is a lot of information there. Just to very quickly remind you, this is part of our statutory mandatory obligations under our Foundation Trust licence that we do this every 5 years. Grant Thornton came in, interviewed a huge amount of people across the organisation, and looking at well-led governance and all the things that we would pick up at the board, around 8 key lines of inquiry. Now, we've had a brief feedback in relationship to that, and I think it was really pleasing to hear Sue, the director who did it, saying it's probably one of the best well-led she's actually done. So thank you, everybody. It is a team effort. And Sue's retiring, so she's done a few of the well-led. But obviously there is always things that we can learn, and we can continue in our continuous improvement journey across, and that's what the action plan is today. So I'm not going to go through the 8 key lines of inquiry. They're there, they are very clear, as is the rating scale. As you know, it's really difficult to get amber and greens, because usually it's around amber red because of the benchmarking relationship to it. So to have all 8 key lines of inquiry either green or amber green is significant. So again, and with the sum of our parts, and that's also the staff across the organisation as well. So we've got 5 greens and 3 amber greens, which is fantastic. We've got no high priority recommendations, 5 medium recommendations, and 18 low recommendations. So if we go through the recommendations, Chair, I would suggest that, because people can ask questions in relationship to the Chloe's, but we have had a presentation. This has been to the governors as well. It's the governors first, so we've taken on board the governor comments, and I thank our governors for that. It was a really good council governors meeting. So if we go through them, most of the actions you will see are well in train and are actually coming up to being completed, which is great. And what we will do is bring this back next month, if that's okay, Chair, just to give people a bit of an update about where we're up to. But it will also go through the committee structures as well, because I do think it's important that the committees own the report, because obviously they were interviewed and it was part of their process. So, for example, if we go through them all very quickly, and then people can comment on the actions as we go through. So the first one was around non-executive recruitment. We're well on that. I'm sure that the chair will give us some update in relation to that at some point, because the process is well underway and coming to final conclusions with the council of governors. Succession planning was the next one. We've done that in relationship to the executive management team. That will be shared, and that will then start to go out across the organisation. So that is well in train. And this was about, we had a succession plan, but this was about ensuring that we knew if it was a short-term succession plan, so 6 weeks, whether it was 3 months, whether it was 6 months, etc. If we had, what we would require in relationship to that, and if we needed to do any extra support, training, etc. So that's there. Quality safety visits have recommenced, which is item 3, and that was a medium one. So they're recommencing. We've already had a couple, and I know that the team are on with getting more scheduled in there. And that comes back to what we've just been saying in relationship to that visibility as well. So they're well in train at the moment. And there was an issue around the geographical patch. And we're having some more conversations about non-exec directors and geographical areas, etc. And again, that's pictured and picked up in the action plan. The corporate clinical membership, this is about programme leads and director of nursing being a member, and I think at the moment it is important that Hilary continues with that. We have got some lead clinicians in there, but what we've agreed is that we will continue to have that handover period. So that's what is collected in the action plan, and what we're saying is that probably from June, but we may just change that given some developments over the last couple of weeks. We'll just see how that goes, but at the moment we'll have that conversation at the collaborative committee. We've had that already, but we're looking to maybe do that in a couple of months' time, in a couple of meetings' time, but we've acknowledged the action. There was a few on film to speak up, and we may want to think about these when we have the annual report later, when Alison comes, our film to speak up guardian. This is about the resource, and Alison and I have had a long conversation about this, because it mentions, have we got enough resource around the organisation, which is a fair comment. If you remember, we've got myself as the executive sponsor, but we've got Alison, who's the guardian, and 2 deputy guardians. We have got a vacancy at the moment that we're recruited to in relationship to one of the deputies. I think what Alison and I are thinking about is having more ambassadors rather than champions, because we've got a lot of different champions around the organisation. So should we have some ambassadors per division and per area? So that's our thinking at the moment, and we'll take that back into, particularly Lynn, really, from an ops point of view, but obviously it will cover the corporate areas as well. So, and we'll agree then by May. Obviously, we've got Dean, so thank you to Dean, who is our now non-exec director in relationship to freedom to speak up, and Dean will have access to the training modules. What I would strongly suggest, actually, we may take this recommendation a little bit further, is that all the board have some sort of training in relationship to freedom to speak up and look at the modules. They're online, so Alison and I are discussing how we can facilitate that easily. And then this was about the Guardian, the Guardian, which we get, the Guardian of Safe Working, the Junior Doctors piece. We get regular updates. Alison's already had that meeting, and we'll continue to do that as well. Assessment of detriment, we've picked that up. It's included in the policy, so that's already been actioned, even though it says May 22. We've actioned that. That is ongoing, as is the data collection, which is the latter one. So a lot of that now has been actioned or well in train. Quality of appraisals, we've had an audit on that, and we'll continue to do deep dives on the quality of appraisals. Staff networks, we've got the exec leads there. The action is continuous, but we've identified, and I thank Steve for picking up some of those, and we'll ensure that they're smoothly running, etc., with that executive lead sponsor. The action log piece, this, if you remember, we had a slight amendment to this. So rather than have the action logs RAG rated for the committees, what we're doing is just ensuring that all the committee structures from the board all the way through the organisation follow a similar process or the same process, and it's clearly documented. And will achieve all groups, and Michelle's already well on with that. We've mentioned it to be April, and we will do some periodic just checks in relationship to that, just to ensure that all the action logs are clearly visible and clearly up to date. The committee assurance, which was around observed meetings, feeding to the committees, etc., and the non-committees, again, we're on with that, and that will be completed by May. And this is about the non-execs, chairing, etc. And we've got allocations, which links into item 14. And we've got now a spreadsheet about that. So when we get the new NED, we can have another conversation. So we've put May on there. That might be the one that goes into June, depending on when the new NED starts, because that's about distribution of workload for the non-exec directors. Item 15 is about the highlight reports. These are the assurance reports that we get. If you remember that they were noted as really good practice, they were really detailed, there wasn't any criticism about them. We just thought, should there be a bit more standardisation so that each of the subcommittees are reporting this in the same way. They all report the same things, but it's just looks slightly different, because obviously you've got slightly different authors. So Michelle's done a bit of a template that's been circulated at the moment around the committees. Board assurance framework risk, that's been in train now with Oliver. Oliver's on with that with myself, and that again, that will be fed back by May. And there wasn't any criticism of the BAF, it was just like an overarching statement. It was there, but just to pull it out, and we will do that. We're on with that very clearly. The next one is done, and obviously just because we say it's done, we will check it's embedded. So we are really quite positive with our action plans in relationship to part of Michelle's role is just to check that it's embedded, that we say it's closed, but the action continues. So this is about just the reporting of the risk registers, and how make sure that the date is recorded of when that initial risk went onto the risk register. So that's been done. The other medium one, item 18, was the one that I constantly raise at committees, to be honest, which is where you get a current risk and a previous risk. So say, for example, you put a risk on that's 20, and you've done a load of different actions and it's still 20. We need to understand why it's still 20. The action's not effective, or is there a reason for that? So that's been picked up there, and I know that's ongoing at the moment. Moving on very quickly, I'm sorry, I know I'm racing through this, but we have seen it before, but this is just the action plan for signing off today. So we've mentioned the risk ones. Management of risk, the presentations of risk are not person dependent, and Hillary's already completed that, etc. And the execs will be expected to do that at committees, which was in train anyway. the financial reports of the integrated performance report, you'll notice today that our report says performance reports. It had integrated performance report on, and it had some slides in relationship to the finance. So just to keep the two separate. So that's what we've done. We wanted to keep the separate finance report because we think that's important, especially as we continue with that planning piece. So that's already been actioned. The division of performance accountability reviews, this is about the clinical director attendance, and I know that Lynn's got that in hand. And as I said, there was a little bit of an issue about the timing of those, but we know that they're related to a risk rating scale, which Lynn manages effectively. So that was about that. Going on to 22, this is about the integrated performance report again, and a select number of indicators and how we present the front sheet. So we've done some more narrative on there around the statistical variation, and that will be work in train, and that will be concluded by the end of May. So we're trying to keep the timelines of these really tight because they're not massive pieces of work to do. So we need to action them, get on with them, and then actually just check that they're embedded. Data quality assurance indicators, this is in form that users that do we have a kite mark? I'm not going to go there. I'm looking at Pete at the moment. I'm trying not to look at Pete. And we'll continue to have that conversation, but that may be one that we just say that we are where we are and we feel that we've got enough checks and balances in place, but that is a low requirement. And then what was fantastic is that Chloe 7 and 8 did not have any recommendations at all. So I know that was a whistle-stop tour, Chair, but we have seen the report before. We haven't seen the detailed action plan. I know it's been circulated, but this is it today. So what I would just like is any comments from the board on either the governance review or the action plan. As I say, the action plan will go into the subcommittees and be monitored and noted by the subcommittees, but obviously the board will have that overarching assurance piece in relationship to the action plan, so we need to own it today. So I'm going to pause for breath. People will be pleased to know. So there's 3 recommendations. One is to formally accept the recommendations, which I've been through as part of the action plan. 1, to look at the action plan. Do they meet the requirement of the recommendation? And to note that we will get monthly updates until the plan is delivered, and then we will get probably a 4 monthly report just to make sure that the actions are embedded. Thank you, Chair.
Thank you very much, Michelle. Are there any comments or questions before we go to approve those 3 recommendations? Hanif.
Thank you, Chair. Apologies, colleagues, a bit under the weather today. Michelle, appreciate the comment on the timelines, and I absolutely see the rationale for keeping those as tight as they are. But are they realistic in terms of fully implementing the action? I certainly think May and June, now that April's nearly over, is fine in terms of that first check. But 1 or 2 of those look like they may need a deeper dive. Do we need to come back at some point as NEDs and just review this, as I say, in terms of whether we've fully implemented the recommendation beyond the end of June?
Have you got anyone in particular, Hanif, that you think that we need to because there's a conversation today. We've had a look at them around. We think they're all doable in that time frame, but is anyone in particular you want us to look at?
No, I was just looking at the different tiers in terms of, you said, the low and the mediums. So if you feel, as you say, that both of those different categories are fine by the end of June, you know, I'm happy to accept that. Just as you were going through them, I was just thinking about everything else that you as the executive management team have got over the next 2 or 3 months, and then coupled with this as well. So it's a supportive comment more than anything else, in terms of have we got the capacity within the team with everything else that you're looking at that we've been discussing, as well as getting this implemented to the high standards that I'm sure you'll want it to be at.
Absolutely, and I was second as supportive, Hanif, and I hope you're feeling better soon. You do sound like you've got a real cold there. Michelle, do you want to go? No, Michelle's got a hand up, so if you don't mind, Jane. Michelle, did you want to come in there?
Thank you. Yes, just quickly. The presentation you've just made, Michelle, demonstrates the amount of progress that's already been made. And to answer Hanif's question, yes, this is doable within that pretty tight timescale because they are things that are already in train. However, just to remind the board that the external facilitator, we do have that scope for 6 months after the review to come back and check in with us. So that will be another kind of validation of how the delivery of the action plan has gone. Whether we use that or not, we could also just have a 6 monthly embedded kind of update to board.
Yeah, thanks, Michelle. I think that's what I meant by 4 months after that, 'cause by the time it's completed, the 4 months after that will be the embedded piece. So, but I mean, we're happy to that. I mean, I think Francis put. I've just had a quick thing that's just popped up that Francis has mentioned about the governor visits in June and what have you. So, I mean, I'm happy to look at extending those two till June. I mean, if we do them quicker, then that's fine. If we get them implemented, I think it's the embedded nature of them that's important. But it's a good point. We can think about that. So, yeah, thank you.
Thank you, Dean.
Yeah, thank you. Mine was just a broad comment. Really, it's one of those sort of things, isn't it? As a board, that we're constantly looking at information and data and ways of finding out things about the organisation to make sure it's progressing the way that we want it to progress. And these external reviews are important additional bit of assurance for us to do that. So it was just really. Not just looking at the action plan, but the fact that this report has been done is actually a very positive story, I think, about the progress of the organisation over a number of years. So that's sort of really welcome to receive it. And it's just to thank all those people that have been involved. So although Grant Thornton came in to do the review, it did involve lots of conversation with staff at a very busy time, and they put their heart into that to give us that sort of information. So it's just to thank everyone from that, and just to welcome it as a positive report. And I think you're right, Michelle. We can then look at the action plan and sort of implementing that as part of that continuous improvement journey. So thank you.
Thank you.
Thanks, Dean. Stuart.
That exactly that point I wanted to make, Dean. A very strong endorsement of the work we've been doing. So well done, everyone, for that. And I'm happy to support the recommendations and the timescales. I think it's right to set some challenging timescales to be realistic about doing them. The only consideration I have, and I've been thinking about it quite a bit, is the one related to it's number 16, the recommendation 16, I think, on the overarching risk statement. And I'm not going to die in a ditch over this one. I'm not disagreeing with the recommendation. I'm wondering how much value we'll get from defining an overarching risk that says more than something bad's going to happen. And then to understand it more, you immediately start drilling down to the subsidiary risk. So let's do the piece of work, but I'm sceptical it'll really add much. But my overall point is this is a really strong endorsement of work we're doing. Well done, everyone.
Thanks, Stuart. I can tend to support your point, actually, to be honest. But let's see, and let's try to make it fairly succinct, I think, is the other thing as well. We don't get into an industry with it.
Thanks very much, Stuart. Is there anybody else's hand up? Let me just have a look. There isn't. Just one thing I wanted to pick up, Michelle, is just on the visits. I mean, I think the actions there are fine. I think following discussions with some non-executive colleagues, but also governors yesterday at our governor development session, it might be helpful, outside of the board, to just have a bit of chat to clarify about, the shape of visits, who goes along, but also just I noticed it says the IPC guidances have been updated. It might be worth sort of sharing some of the key points of that, of what's changed and how that will play into the visits themselves. So I think there's a little bit more work there to join up what's already in the action plan. So we're clearer about where we're visiting, how many people should go, how many visits you can do a day, and so on. And of course, it's not just the inpatient services, it could be our primary care services as well in the community, who I think, might welcome seeing some of us occasionally to show that we're interested in what they're doing too. So, I mean, is that okay if we could just sort of maybe shape that a bit more so we're clear, because they haven't been happening for so long. And my sense is from governors, some have experienced the visits before lockdown, some have never experienced a visit. So there's different levels of sort of understanding and knowledge about what they can expect. And I think what we can expect as well as non-execs too. Is that okay?
Yeah, so can I suggest on the third one, I think that's what we're talking about, picking up Penny's point earlier on. So if I suggest we change that date to the second part to June, and then what we do, only because I think Francis's point about getting everybody together, but then we have got we did do a bit of a briefing pack before COVID in relationship to what the knowledge visits were, etc. So we can it's not connected to this, but it is, if it is not directly connected, but it links in. We can update that. We can update the IPC and we can get that out as well. But we'll just change that date to June if that's okay, and then we'll do that as well, which is a subsidiary piece. How does that sound?
I think that's fine. I think we might as well spend a bit of time just having a relook and a refresh on this. That'd be great. Thank you very much. I can't see any other questions, so thanks for that. And just to echo what others have said, I mean, first of all, thanks to Grant Thornton, because actually they did an extensive process, but everyone put a lot of time and effort in all parts of the organisation to provide the information that they needed and share our experiences. And actually, I think it's a really good outcome, whilst there's some, I think, real learning there as well, that has to show that we are always an improving organisation. And also, just to reflect back, I think the governors were, very pleased. It might have been just the cycle of events, but they were really pleased to actually receive the report at their meeting. And they had comments as well, which obviously will be fed in. But I think, overwhelmingly, they wanted to express their pleasure actually at such a good report and such an assurance for what's happening in the organisation. And I think Tim Durkin in particular wanted to sort of share his thanks and really welcome the report, but I think he spoke for all the governors. So without further ado, can I see, there's 3 recommendations: to formally accept the report and the recommendations, to approve the action plan and address the recommendations, and to note monthly updates will be provided to the board until delivery of the action plan is complete. Is there agreement for those 3 recommendations? Yes? Thumbs up. Anybody against? No. God, I feel like I'm in the House of Commons. There we go. Right. Okay. So thank you for that. Thanks and well done. Well done. We'll go back then to Charlie and the staff survey, the patients. Staff survey, and he's from Quality Health. Are you going to introduce him for us, Steve?
Yeah, we'll do. Thank you, Caroline. Thank you. So a presentation on our staff survey. Now, very conscious that we've done a couple of presentations on this. We presented to our governors, and obviously board have had some information before, but you'll be pleased to hear it won't be my voice you're hearing again. So Charlie's going to present. So we worked with Quality Health this year for the staff survey, and as part of that, they present back to us, and they will present back on our results. So Charlie, you're very welcome to our board. Thanks for your support so far. I know that the timing made it such that literally I think our last board was the day the results came out, so we couldn't quite get all of the benchmark information and that kind of context. So we decided to push it back to this particular meeting, which I think is sensible and gives Charlie more time to absorb all of the results that came in and hopefully be better prepared if we have any questions. Not to put you on the spot too much, Charlie, when I say that. So I will shut up and hand across. Charlie, welcome.
Thanks very much, Steve. And hi, everyone. Yes, very happy to take questions, Steve, at the end. That's absolutely fine. I'm just going to share my screen and then take you through a presentation. It's got a fair few slides. Do not panic. I'm going to be quite quick on some of them. So I'm going to talk to figures that are interesting or are telling you something, and ignore some of the other bits that don't tell you such an interesting story. Let me just share my presentation with you. Can everyone see that okay? Yeah, good.
Yeah, good.
Okay. So hi everyone, I'm from an organisation called Quality Health. We're a company that delivers these staff surveys. We are not part of the CQC or NHS England, just to make that clear with you all. We are part of a much bigger company now called IQVIA, and this slide shows you some of the things we do across the NHS. So the national results, as Steve just mentioned, have been published. They were published at the end of March, which I think might have been the day of your last meeting. So there wasn't quite enough time to put the presentation together. So all the results in this presentation you see will be based on the results from every trust, because this is the report that's been put out by NHS England. This year, you probably will have noticed that the staff survey's changed, as it does most years, but has considerably changed to include these people promise themes. It used to be key findings, and then it was just themes, and now it's people promise statements. And I'll come on to those as I go through the presentation. So firstly, just to have a look at your response rate. You've got a response rate of 44%, which is very good. It's slightly below the median at 52. But we always say anything over 40 is really good and gives you a really good understanding of what your staff are saying. We have some that are as low as 18%. So don't be concerned by the fact that's below the average. One thing we would always recommend to improve response rate is to publicise what action senior managers have taken as a result of the results. And the best methodology for that still is that you said we did model. So if that's not something you already do, to post something like that after the staff survey will really get staff filling it in the next time round. Here are those people promise themes, and as I go through, the dark blue is your trust, and there's some slightly different looking charts. So you will see pretty much above average in most of them, if not above average, sort of slightly level. And there is one that's very slightly different as I'll come through. But on the whole, especially where we are at the moment, and delivering care through a pandemic has been challenging for everyone in the NHS. So there is a downward trend, and your organisation is very similar to that trend. However, these are encouraging results. There's no nasty surprises here. On the whole, results are good and indicate a trust that's performing well. So just breaking down some of those people promise themes, the one on the left there shows that we are compassionate and inclusive is the theme. And really good scores on diversity and equality, which is really encouraging. They're quite difficult to get right, I think, especially at the moment, but very slightly below around leadership. But I'll come on to why that score's slightly lower than the others. The other ones there all around average. Safe and healthy is okay, all around average, apart from negative experiences, which is around harassment, bullying and abuse and violence at work. It's really slight. You'll see the difference between you and the national average, but there might be one or two scores that are affecting that. And again, I'll come on to those. But good scores around learning and development, particularly around appraisals, well above average, which is really encouraging because it directly feeds staff engagement when people have a good appraisal that makes them feel valued, for example. Great scores on flexible working, really challenging one to get right, especially at the moment as trusts have had to kind of reposition staff quite quickly through the pandemic, well above average. And team working, all okay, you can see, sort of roughly average there. Staff engagement is broken down over these three themes you see on the left-hand side: motivation, involvement and advocacy. Advocacy is a really important one because it's where the CQC tend to look. And it's got the NHS staff, friends and family test questions, and I will come on to those because they're really important ones to keep your eye on and drill down into the data a little bit to understand where the scores are coming from. But good scores on thinking about leaving. So fewer staff in this organisation are thinking about leaving compared to others, which is really good. Slightly below on work pressure. Again, one we'll come on to a bit. These slides are really awful, and apologies for that. It's not our chart, but because of the scale, you can see it's very difficult to see. But I just thought it was an important one to show because you're the dark blue and the light blue is the average. And then there's the one at the top and the one at the bottom, which are the top and bottom performers. But you're really similar to the average here. So although some of your scores are dipping, I just wanted to show you that staff engagement, which is the overall indicator of how the trust is performing and how engaged staff are, is actually exactly on average and has moved in a very similar way and has actually increased very slightly since last year, which is encouraging. And morale tells a very similar story. In fact, very slightly above on overall staff morale, which is good. More information on some of these themes, and as I say, I'll skip through these quite quickly. And apologies if these look like horrendously busy slides, but I will point out what to have a look at. So in the slides that have got these 4 lines on them, the 2 right-hand side ones, have a look at that dark blue line. That's the way you're performing, and the light blue line is the kind of average performance. 21A, which is the middle one, which is staff agreeing patient care is the trust's top priority. You'll see has come a long way from back in 2017 when there was a big difference to now. It's followed a very similar trend, still below average, but definitely closing that gap, which is encouraging, but one to keep your eye on. 21B is staff agreeing the organisation acts on concerns. That also is closing the gap quite considerably, which is good. Now, these 2 are the ones to really keep your eye on. So 21C is staff recommending the trust as a place to work. It has gone down very slightly since last year, but you will see that is the trend nationally. In fact, what it has done is not gone down as much as it has compared to all the other trusts who are in your comparator group. You are starting to close the gap. But much more encouragingly, the one on the right-hand side there, which is staff agreeing they would be happy with the standard of care if a friend or relative needed treatment. You'll see that has now gone very slightly above average. So where the national trend has gone down, you've gone sort of across, kept level really, and as a result have come out on top. That is really encouraging. It's a really important question to look at. And I suggest that is indicative of a trust which is striving to deliver really good care, particularly during challenging times. So that's a good score. I'm not sure if these slides tell you too much, just that you're below on things around immediate managers. So that's more the middle manager level. This generally tends to be line managers. So slightly below on staff feeling their line managers listen to them or help them with their problems. I mean, some training for line managers could probably help in that instance because they're not too low. It's just very slightly below. And you'll see very slightly below again on caring about concerns and again helping. Here are the diversity and equality scores. So firstly, really good improvements over the last couple of years on how organisationally staff feel that the trust takes seriously issues around diversity and equality. And secondly, around discrimination. So have staff, experienced discrimination from patients and service users. You want that score to be low. So the fact you're towards the bottom there is really good. In fact, you'll see the green line, which is top performers. You were bang on that in 2020. It's very slightly different. It's gone up a little bit, but it's a good score, well below average, which is what you want there. And 16B is have staff experienced discrimination from team leaders or managers. That's a really concerning one if that's high. You'll see it's very low, it's below average. I'm sure as a trust you'll want to know why it's on there at all, but you'll see even the best performers is only just below you. So this one around being recognised and rewarded, I think is a really interesting one. So the middle one really is to point out to you all how well do staff feel valued by the organisation. When staff feel valued, we know they're really engaged, less likely to be stressed, less likely to take time off. And this is a really encouraging score. You're very slightly above average, but over the last few years, I mean, you've grown hugely in terms of how staff feel rewarded from, looking at almost one of the bottom performers down in 2017 to above average this year, which is really encouraging. And satisfaction with pay, which is a really difficult one to get right, well above average, which is the one on the right-hand side. Less positive on how immediate managers value the work of staff, which is the one on the right-hand side there. And that, again, is an important one to get right. It feeds lots of other scores. So the fact staff feel really valued organisationally, but less so by their manager, suggests there could be some work you could do with managers, immediate managers, to help improve that score, and probably some of the other ones. On to staff having a voice that counts. These scores very slightly below average, apart from the one towards the end, which is almost on average. Staff having opportunities to show initiative. But the other two, a bit below average, staff knowing what their work responsibilities are, and staff feeling trusted to do their job. Actually quite close, that one. This one is around sort of autonomy and control and feeling that staff can make suggestions to change things in their department and having a voice that's listened to. All of these are okay. They kind of show a broad, similar trend to the national trend. I suppose the one around staff feeling they can make improvements has dipped quite considerably, but it has done nationally, and probably not unsurprising in that it's not the best time to be making changes and improvements happen. where things have had to be changed due to the nature of delivering care through COVID-19. I don't want to keep mentioning COVID-19 as an excuse, but clearly it's had an impact on lots of scores, and we can see that as an independent body because they've dropped in ways that we haven't seen before, and it's ones that are quite obvious. Staff feeling safe and healthy. So there's some important ones to point out here. Staff less positive around meeting conflicting demands, but really positive around having adequate materials, supplies and equipment. This scores, lots of trusts have really find this score challenging because it's not just about PPE or medical equipment on wards, it can be about access to IT equipment, remote working, does Teams work when people need to connect to meetings. So lots of trusts have seen this one drop. The fact you're above average is really encouraging. And a very similar drop on the right-hand side around staff feeling that there are enough of their colleagues around to do their job, but around average. Sorry, middle one there to look at, which is do staff feel the organisation takes action on health and well-being? Slightly above average, which is really encouraging. Health and well-being at the moment is a really difficult one to get right. This indicates staff have reacted well to whatever initiatives the organisation have done. So I hope you can see that that's as a result of action you've taken as a trust. If you've done work around health and well-being, particularly during lockdown, I think staff have reacted well to it by these results. One on the right-hand side there is reporting of physical violence. That's a little low. You want that to go up. So where staff are experiencing violence at work, they are reporting it, or a colleague's reporting it. It's not an area to be concerned about. It's not really low, but it's below average. And similarly, HBA. So where staff are experiencing harassment, bullying and abuse, they're less likely to report it compared to your comparator group. So just having a look at some of the negative experiences here, there's not too far to go. These are really important ones. I know I say that to many of the scores, but these ones in particular directly feed staff engagement. So the first one on the left list, staff experiencing musculoskeletal problems. You want that to be low, so it's very slightly above average, but only very slightly. And you can see it's dipped since last year. So again, I hope that's as a result of action the trust has taken. But increases in work-related stress, very similar trend, but above average. However, not too bad on staff coming to work when not feeling well enough, which is the one on the right-hand side there. These ones are the really important ones. So physical violence, and we know the CQC is interested in these. Less so the one on the left, which is where it's happening externally, i.e. from patients and the public, but very interested if it's happening internally, so where the trust can take action, particularly around managers and other colleagues. And you'll see, I mean, very almost average, those scores. But I'm sure as a trust, you know, which strives for excellence, you'll want to understand why and where those scores are coming from, because it will still be in real terms a fair few staff who are experiencing that violence from managers or from other colleagues. But it is around average. It's not too high. You'll see the orange line is the ones, the really low performers, but definitely one to have a look at. And similarly, harassment, bullying and abuse. So the one on the left from the public, and then the two on the right where it's happening internally. Both of those are around average. However, we always say don't just think, well, that's okay because it's around average. It's still high, but it is high across the NHS, certainly compared to other sectors. So 15% of staff experiencing it from their colleagues. One to have a look at in a bit more detail. Drill down into your data. It's almost certainly going to be hot spots of where that's happening, and taking some local action can really help to reduce that. Learning and development, this was the one that was slightly lower than some of the other scores. So staff less positive around having career opportunities, the middle one there. And staff were slightly more positive than the average around feeling supported and access to the right learning tools. These slides show you about appraisals. So looking at the one on the right hand side is around, do staff feel that they leave their appraisal being better able to do their job? So does it help them improve how they do their job? And that scores slightly below average. The one on the left, coverage of appraisals, is really good. So lots of people are having them, which is fantastic. You might want to just review the sort of content of them to try and bring that score up a little bit, because it's slightly below average. And so probably unsurprisingly, less positive around feeling their appraisal helps them agree clear objectives, or that their work is valued. The appraisal is a really core opportunity to make staff feel their work is valued. And it's an interesting one because in the other question, organisationally, they feel their work's very valued, less so from immediate managers and appraisals. For working, some really good scores on here, particularly at the moment. So look at the left-hand side. Organisationally, start off very positive around how the organisation meets the demands of staff who might want to work flexibly. And you'll see overall opportunities for flexible working well above average. Good scores on team working really suggest people feel well supported by their teams. So get respect from their colleagues, meeting often as a team are all above average. These ones we've already covered. So some questions are used more than once for the people promise themes. Less positive around immediate managers. We've looked at that one, and similarly again. Almost there. I know I had about 20 minutes. I might have gone over very slightly. So motivation on staff engagement, you will see very slightly below average, looking forward to going to work. But the other scores, particularly on the right-hand side there, just about average. And very similar patterns for involvement within staff engagement. Again, I think we've looked at these questions. They were in a different category as well. These are the FFT questions, just showing you in a slightly different chart, but you'll see below average on 2 of them. But morale is good. And as I said at the beginning, this is a really important one to look at because whilst you've seen some scores that have dipped, I don't want you to be too disheartened by that because actually, generally, morale is okay and staff seem to be reasonably well engaged. But staff often thinking about leaving is a bit above average. You'd like that to come down a bit. The other 2 are okay. Work pressures. Again, the one on the left-hand side there is the one to look at. Staff feeling they can meet conflicting demands on their time. It's a very similar trend to the national trend, but it's gone a bit below the average figure. These are the stressors that staff feel, so it really affects morale if some of these are significantly below average. But you'll see that one in the middle there, staff feeling involved in decisions. It's a really difficult one to get right, and actually you're above average on that one. Particularly at the moment, it's a challenging one, so that's a good score. These ones are all around average, except the one on the left-hand side, having a choice in deciding how to do their work is really good. And again, a difficult one at the moment because of the nature of repositioning staff, perhaps. So that's all the numbers. Hope that didn't feel too overwhelming. Sorry, there's quite a lot of them. So I tried to go through those as quickly as I could. Just a couple of slides on recommendations. This is what, as an independent body, we would suggest you have a look at. But these very much are recommendations. You, as a trust, can choose to do some or none of them if you like. Have a look into your data on some of the lower scores, particularly in advocacy. So that's the FFT questions. So staff who would not recommend the organisation as a place to work. And see if it's a particular staff group or demographic that's answering that question in that way, and see what local action you can take, and maybe consider focus groups with staff to unpick some of those issues. So with morale, the scores were actually good. So where I say investigate low scores on morale, I mean the ones that were lower than the others, because actually morale is okay. But do focus on staff who don't know what their work responsibilities are. I think that was an outlier. Stress at work has definitely gone up and is high. It's high across the whole of the NHS. I think everyone is over 40%, and I think you're approaching 50. So almost half of respondents feeling stressed. So have a look at that one. And look at appraisals. As I said, the coverage of appraisals is really good, performing excellently, but some staff feeling they could be clearer in terms of agreeing objectives and definitely feeling valued for their work. Immediate managers we looked at have a consideration for some training for immediate managers so that they can better support their direct reports, including around health and well-being and valued. And again, I've mentioned making sure staff continue to feel recognised and rewarded, because it really does feed stress at work and ultimately sickness and absence. And finally, before I finish, do remember, and I know I've said it throughout the presentation, but scores throughout the staff survey presentation have been considerably affected by the pandemic and the way in which trusts have had to respond and deliver care. So do recognise that and do celebrate positive scores, because actually in a really challenging time, the trust is performing well. Thank you. It's a very quick canter through the results. I will stop sharing my screen so I can see you all if there are any comments or questions.
Thanks very much, Charlie. And obviously we had a board time out recently where we had a discussion about some of these results, and the governors actually also had a presentation at their last council governor meeting. But thank you very much for pulling that together. Will we have the slide deck shared with us, Charlie?
Yeah,
brilliant.
absolutely.
So we can circulate that around. Brilliant. Thank you so much. Right. Any questions or comments from any colleagues on this? Goodness me. Dean. Thank you, Dean.
Yeah, thank you. I guess, Caroline, this just resonates with some of my earlier point about the sort of well-read review as well. So just, headline sort of stuff, a very, positive set of results over the last few years. So those first few graphs that were showing, where the organisation was 2017, 2018, significantly below average and sort of coming up that sort of journey. And we know that a lot of this is cultural, doesn't we? It sort of takes time. It's not necessarily an overnight fix. So that gradually sort of working on those areas. And the second thing was, the suggestions about the recommendations to work on. I know one of the things that Steve and the team do, and we do through the workforce committee, is that idea of intentionality. Where can we put work and effort in terms of what this is telling us, to use that sort of evidence base about the work that we are doing. And then the final one was just a technical thing, just to reassure people, just in case anyone was any staff are listening, Charlie, when you talk about drilling down into the data, we don't get data from individual staff, so this is confidential. So I think what Charlie was talking about is, any particular areas or staffing groups rather than individual sort of staff. And I know that's implicit in what you were saying, Charlie, but I just thought if particularly staff are sort of listening into this, that they can be reassured that all the results are confidential. And I think we can't look at, where any less than 10 responded. We can't even break it down there. So it just gives us that sort of reassurance. But definitely doing that sort of work, I think, through the workforce committee and Steve and the team, look at that variation across the organisation and how the different divisions can sort of work on their own action plans that make a difference to staff in those areas, I think will be important. But thanks for the update, Charlie. Really comprehensive and much appreciated.
Thanks, Dean. And I just wanted to follow up and say absolutely around protecting the anonymity of staff is a legal obligation of ours. So there's no way we could identify any individuals, even by comments which are made. So all comments are sanitised. If anyone leaves a free text comment and mentions a name or a staff location or a job title, that's all taken out before the trust sees the data. Thank you.
Thanks, Charlie. Thanks, Dean. Stuart.
Yeah, just to build on that, I think it's really important for teams individually, when I say individually, in meaningful groups, to get to understand the results for their area and to discuss them, because only really understanding what the mood of the camp is in localities do you then get the sense of how do we improve. So I'm just looking for assurance from the execs that kind of process can happen.
There's nodding happening there. Yeah, maybe Michelle will come back to that when I call Michelle. But is anything else, Stuart?
That's it. Thanks.
Okay. Thank you, Hanif.
Yeah, thank you for that really informative presentation, Charlie. I just wanted to ask a question. When you're looking at these across the trusts, is it just a case of the analytics, i.e. the number crunching, or do you get to identify almost patterns of best practice that can be shared to help drive up some of those areas where we might be slightly below?
Yeah, in terms of the sort of best practice and actions trusts are taking, it's more anecdotal than sort of statistical. But we do have quite a lot of that. What we suggest in this instance is that we can connect you with the top performing trust in any key areas. And it's absolutely not the same. It's really different in each question. So it's not one that, I mean, there are some that are quite good, but not one that's top on every question. So if there are 2 or 3 areas you really want to focus on, we can connect you to the top performer to kind of just have a chat around what they might have done to improve results.
Great. I think we'd welcome that. That'd be helpful. Thank you.
Very much. Thanks, Hanif. Michelle?
Well, it links to my question, because I was going to ask exactly that, which is if you, because I know that we have asked that before, and I think that'll be really helpful information to go into the action plan report. So anything that you can share, Charlie, with us in relationship to your high performers, etc. I mean, obviously we would like to be that organisation that does the tops for everything, and that's what we're striving for. But no, seriously, if there's anything, please point us in that direction. That would be really helpful, because obviously we can share our experiences with with others, but also we would like to have that sharing of other top organisations. So I'll leave you to speak to Steve and the team in relationship to that. I'm sure that's happening already. In relation to picking up some of the points, yeah, we have got the divisional plans, the divisional responses, and yes, they are not individual, absolutely categorical. It's all anonymous, but the divisional ones at the divisional levels have gone out to the divisions, and I've personally got mine. I've had my first conversation with my team. I'm having another conversation with the exec team, and then the communication team. So I've just divided it into 3 pieces. So obviously that will continue throughout. What I was going to suggest is that obviously we need to keep this as a regular item. I think you've just set the workforce committee's agenda in relationship to that last couple of slides in relationship to what we're going to ask the workforce committee to major on, but I think they need to do that through the organisational development group and through the executive management team up to the workforce committee and then up to board. So that picks up the previous comments as well, and I'll leave Steve to get that in hand, which I'm sure there is. But just thank you for a great presentation, and thank you for everybody within the organisation and within the team, because as I say, for me it's that journey, that continuous journey from 2017, and we need to continue that as well, because obviously staff are our greatest assets as well. So we do need to look at some of the areas where we're not performing very well, but also keep at the ones that we are. And I think sometimes there's a little bit, you concentrate on the areas that you're not quite there, but we've also got to continue doing the stuff that we're doing slightly better or on average to keep that up as well, and that's the balance as well, I think, is important. So I do stress that to the workforce committee, that we've got to look at it in the totality. But thank you for that great presentation and your work on pulling the results together as well.
Thank you. Thanks everyone. Thanks for having me.
Oh, I was just going to okay. I was just going to ask you something, Charlie.
Say again, sorry.
Still there, Charlie? You're still there?
Still here.
Thank you. Thanks, Michelle. I just wanted to just maybe something to take away, and maybe you can, through Steve or someone, maybe sort of help on this. I mean, this is a snapshot of how people are feeling, and it's really important, and all the data is really interesting, and of course the benchmarking elsewhere. Obviously, the trust does uses this survey method in different ways, or asking staff what they think about things. And I just wondered, just before you go, in terms of any advice about how we take this and then use that to try and find out more information in real time from people on some of the particular areas which you've highlighted that we need to look at. And so we find out a sort of a weighting, if you like, of what's really happening, because there were some quite almost contradictory responses in some respects in some of the areas that you thought, well, hang on, people feel really positive, but then there's one question where we sort of fall down. And I just wondered any advice in terms of how we sort of correlate all the data we get through other ways of asking staff with what the patient surveys, the staff surveys actually saying.
Thank you. Yes, so some trusts do this quite successfully by doing quarterly pulse surveys. So just looking at 1 or 2 particular issues to track how staff experiencing is changing over the course of the year. So that's something you can explore doing. But most importantly is having a look at the data as it is now by those different groups. So break it down, and using Solar, which is the reporting tool we provide you access to, you can break the data in infinite ways, again, providing it doesn't go to a small number of staff that you might be able to identify. So to break it down by demographic and staff location is the most important thing. And you can have a look at it by, different types of demographics, so gender or age, for example. But in terms of tracking performance over time, pulse surveys, which are small snapshot surveys delivered to staff electronically over the course of the year, are the most effective.
I think we're doing some of that, so it's good to hear you saying it, actually. So
great.
That's another reassurance, so that's good to hear. So thank you very much for your time.
Thank you. Nice to see you all. Cheers.
Nice to see you.
Bye. Bye.
Okay, great. So we move on to item number 8 now, and the Chair's report. Just to update you all that we, this last month, we've been obviously ongoing with the NED recruitment. We completed that on Friday, so we're just in the stage of, obviously there's some formal issues to go through, but we have been able to offer someone the position as a NED clinical, which picks up on the well-led review recommendations, And I will let obviously the board know more about that once we've sorted out some of the formalities, and we've got to obviously get ratification organised by the Council of Governors. The Council of Governors meeting that's happened in recent weeks was really good, actually. As I said, it was very welcome that they had a chance to discuss both a staff survey and the well-led review. I would say a highlight of that was actually hearing from the Humber youth group, in particular Charlie, who came along and talked about some of what was great to hear, the opportunity he's got to get some work experience with some of our services across the trust. I think maybe some of the non-executive directors who were on that meeting felt a bit jealous that they weren't able to go out and do the blood pressure checks with the fishermen out on the coast in the way that Charlie described, which sounded fun but also really important as well. I observed and attended the Finance and Investment Committee, so thank you to Francis and colleagues for that. That was really helpful to be able to attend that. And I am working my way through all the committees in this. I think I've got mental health and legislation coming up shortly. Since we last met, we've had a governor working group that has had representatives of governors, EMT and non-executive directors on it to look at some of the issues around IT support, the different meetings that governors have and individual forums to see, again, I think as coming out of the restrictions that the pandemic had for us, how we could refresh that earlier. And one of the discussions which was highlighted earlier was about visits. We had a really good governor development session yesterday where a draft paper from the working group was discussed. There was some more input from that. I shall be sharing it obviously with the board and also with the governors who couldn't attend. But I think thanks to Michelle Hughes, who's here today, and others who've helped make that happen. That was good. And we had also really good, and we've got Oliver at part 2 today. We had a really good presentation from Oliver on risk, how we assess risk in the trust. And again, governors found that very helpful. That's pretty much the sort of highlights of my last month. Any questions? No? Okay, we'll move on to the Chief Exec's report.
Thanks, Chair. Again, I'll take it as read that people have noted the content of the paper. There's 3 policies to ratify: job planning, bullying and harassment, and attendance management policies. There's also the approval for the responsible person in relationship to the Use of Force Act being the Chief Operating Officer, so that's Lynn. That's a really, it has been dropped for a long time. It came into force a few weeks ago. It's a really important act for all organisations, but specifically our organisation, and there's something in the paper in relationship to that, and we'll get more and more regular updates on that, on the Use of Force Act. But we do have to identify a responsible person, so links into the seclusion and work that we've been doing. So I'm proposing that's Lynn. Other things in the report, I'll obviously leave the directors to pick up their areas, but other things from me, obviously my Chief Exec challenge has been set. So that's going to be on the 23rd of June. It's a static bike, so that I'm going to bike my way around our organisation, which it works out about 93 to 100 miles. So please do come and support me on that day. More details will follow, but it's just to get it in the diary early. We've got our charity golf day set. These are all for Health Stars, and all that money will be raised for Health Stars, and that's on the 9th of September. I've invited obviously some national folk to come and play with me as well, because it's also a really good opportunity just to showcase some of the work of the organisation as well. I won't, obviously Steve can mention some of the things about staffing, because there's a lot happening in relationship to workforce, but I have picked out the Band 5 incentive scheme in relationship to golden hellos for Band 5s, but also for that retention payment for our current Band 5 nursing staff, because they are really hard to reach group. We value all our staff in the organisation, but it's important to get feedback from staff, feedback from managers, and that was one of the feedback, so we've acted upon that. We have given out a small Easter gift to all our staff of £5, just to say thank you and just to allow themselves to buy themselves a little treat over the Easter period. Lots happening in relationship to the Integrated Care Board, which I will pick up, but there's a bit of an update on people. Lots of movement in relationship to people, place leaders being identified, and the Integrated Care Board has held its first shadow board meeting as it moves into that status, getting ready for formal organisation in July. Lots and lots on the COVID bit that I'm suggesting that we don't just call it COVID and winter, the organisational piece. I think it's quite useful for the board just to have a bit of an update monthly. So I'm going to suggest that continues. I'll let Lynn pick up the highlights. Michelle will pick up the highlights from the communication. Just a couple for me on the Health Stars. They had a big fat quiz that took place. I couldn't unfortunately attend. It was a bit short notice for me, so I did a bit of a video just to say well done and thank you for everybody for attending. And lots of wishes have been given out and lots of positive work from Health Staff, so that's really helpful. I'll leave it there, Chair. It's all in the report. I'm conscious of time. I'll just open to questions or my colleagues to answer or just to say anything briefly before questions. So I'll throw it up to my colleagues first. Thanks, Chair.
Thanks, Michelle. I've got Michelle Hughes.
Thank you, Chair. Just to draw attention to the marketing and communication strategy. This is currently being refreshed alongside our new trust strategy and will include a 5-year plan and it will be shared with board in due course. Interesting to know, nice to know that despite the challenges of the pandemic, the transformations across the trust progressed that included the brand, intranet and internet site being developed. I know Hillary's section mentioned a entry into the Parliamentary Awards. We actually did enter 8, so fingers crossed that we're successful with some of those, and we have a number of HSJ awards in progress at the moment. I did wonder when Sadie was speaking earlier whether there's a potential for another story there about developing a patient safety lead in our trust or something, just to demonstrate the journey there. And just finally, I know Michelle mentioned, I think at the last board, there's a period of purdah for the local elections. The guidance doesn't formally apply directly to local NHS organisations, but we are encouraged to abide by its principles, and we are doing. Thank you, Chair.
Thanks, Michelle. Lynn, yeah, Lynn.
Thank you, Caroline. Yes, just to follow up Michelle's introduction around the COVID piece. Obviously, I assume people have read it, but I guess the highlights are just to remind the board we actually still are at a wider NHS is to alert level of 4. It's not been reduced as yet. Infection rates obviously are still high, although they're a bit variable across our geographical patch. We still do have COVID positive patients in our beds. We have 5 today, so it has reduced a little. COVID absence is a bit stubbornly stuck in terms of our staff position at the minute, although the COVID related absence has reduced a little, though the non-COVID related absence, which I'm sure we'll come to in the performance reports, is still high. Operational pressures, whilst they were reduced in my last report, unfortunately they did escalate to Opal 3 for us, although we have reduced them as of the end of last week to 2. Which is better, but the system pressures, as we described last time, really haven't changed a great deal during the last month. They are still very high overall, with the acute hospitals predominantly being at that Opal 4 position. Our focus obviously has been really on planning submissions as well in the last month. Pete can tell you more if needed, but that has obviously included recovery of trajectories across some key service areas. Main areas are covered again in our performance report anyway. And as ever, and we discussed it last time, our focus, and obviously connects to the staff survey presentation that we've just had, focus on staff health and wellbeing obviously remains very key. Overall, as I say, that's the position. I think it is important, as Michelle says, that we keep on looking at that in the board going forward, because it is impacting still on service delivery. Thanks, Caroline.
Thanks very much, Lynn. Hilary?
Just wanted to draw the board's attention to the Ockenden report there that's in my section, the review of maternity services at Shrewsbury and Telford Hospital. Obviously, we don't provide any of the services that are within scope of that report, but there's 79 recommendations made in total. I'm just going to start looking through all of those, pull out the ones that could be relevant within our context of our services and produce a report. Bit of a gap analysis, really, I suppose, of what our current state is, if there's anything further we need to do, and obviously we'd pull any of that into the refresh of our patient safety plan as well going forward. Just wanted to make sure the board were aware of that as well.
Thanks, Hilary. It's good to hear that gap analysis is happening, and we're taking a look at this for our services, even though they're not directly the same as the Ockenden report covered. Thanks for that, Hilary. I'll go to Francis.
Thanks, Chair. Just a quick one, as ever, a really comprehensive report, which is great. I just liked the bit around the development of virtual wards, which sounded really interesting. I was wondering if somebody could expand a little bit on that, and also will any issues in terms of local government cost savings, etc., potentially impact on any of that? But looks really interesting.
Who'd like to come back on the virtual wards?
Lynn, do you want to pick that
Lynn?
up?
Yes, thank you. Thanks for the question, Francis. I do think, as you say, it's a really important. Virtual wards are not new, actually, but obviously the position that again described around the acute hospital pressures, wider system pressures, there is new investment in virtual wards. Virtual wards can follow clinical pathways, so our particular proposal was requested to be focused on frailty specifically, so indeed that's what we have done. They do exist for other pathways, so for example you can have a respiratory virtual ward as well, but obviously the whole idea of them, as is described in the report, is with intensive support, that wider multidisciplinary team, a reasonably small caseload as well, which I think is quite important in terms of being able to provide that intensive support to avoid hospital admissions in the first place, but obviously to support hospital discharges too. So we're really pleased that we're in a position to implement our plan. It'll be focused on Scarborough particularly, but our hope is it will be expanded as we go forward as well.
Excellent.
Thanks, Lynn. I seem to recall we used to have community matrons who used to have a caseload of 50, and the idea was that was part of their job to keep people out of hospital, wasn't it? But a good idea is a good idea. It just needs updating, doesn't it? Thanks for that, Lynn. Hanif.
Thank you, Chair. Lynn, just in terms of your update on the COVID situation and correlating that with the revised guidance that Dean sent out, I think it was last week, wasn't it, Dean? Is there any intention at this stage to change the way we're operating to align ourselves with that new guidance? I know up to now we've taken a very cautious approach, which is understandable.
Yeah, so in my report, obviously, Hanif, there's reference to two sets of guidance. So I guess the first thing is to say guidance has been changing quite rapidly. So and from our point of view, we've been trying very hard to make sure what we communicate to our services in line with that guidance is clear, quite precise and simplified where it can be. So I mean, Hilary might want to comment, but overall we thought that we were generally in that direction of travel anyway. This is predicated on a risk-based approach, which we'd already adopted as well. Our suggestion is obviously it has impacted, which we have adopted again on a risk-based approach. So for example, where areas can reduce to the 1 metre distancing, areas are doing that now, so but within a risk framework as well. So, and we have made our suggested guidance, which probably slightly differs, is that we would want our staff to continue to wear masks. Obviously they have to in clinical areas, but we'd want them to do that in non-clinical areas as well, just to protect their health primarily. So we have communicated that to our staff. So, but Hilary might want to add a little bit more.
I don't think there's much more to add to that, other than obviously we're following the guidance now and stepping down patients that we've got on our units that are positive on day 7, pending their LFT tests, obviously. But again, if they've still got symptoms, even if their LFT test is negative, we're saying it still goes through then to 10 days to keep everybody safe as well. So we've taken the guidance that's come, and we've just made sure, as Lynn says, from that risk assessment, that what we're telling our staff is all couched in assessing the risk. It's not black and white, and using your clinical skills as well, and common sense really to keep everybody safe.
Thank you, Hilary. I've got Mike next.
Thanks very much. Just looking at the Mental Health Use of Force Act and the cover sheet saying it's Quality Committee supported by Mental Health Legislation Committee. When we've looked at this sort of issue in the past, and I suppose the clue is a bit in the title that it's an act. When we've looked at reducing restrictive interventions, when we've looked at ligature risks, Mental Health Committee has looked at the legal requirement and then passed on to Quality Committee deep dive work into the quality implications. And I'm just thinking that when I first looked at this paper, it seemed to me that the primary reporting line should be to Mental Health Legislation Committee, with quality implications passed over to quality. And I'm just wondering what the thinking was of EMT when they looked at this.
Yeah, I'm happy with that. I think that's really, yeah, that's exactly my thinking, Mike. I think in relationship to the primary committee, in this case is the Mental Health Legislation Committee, supported by any quality initiatives or quality issues to go through the quality committee. I also think, given its importance, and I think it'll be one of the areas that the CQC will major on. We've already got a link into the guy that's working on it in relationship to the CQC. But I also think from a board perspective, it will be helpful for the mental health legislation, maybe just to in about 3-4 months' time, just to put a big part of the report in relationship to where the Mental Health Legislation Committee thinks we're up to in relationship to the Mental Health the Use of Force Act.
It's really helpful. Thank you, Michelle.
Thanks for that. That's really helpful. Make sure that's in the action log for us to come back to at a later date. Dean.
Yeah, thanks, Caroline. Mine was just a question probably for Steve, just around the ratification of policies that are in the paper. There's 3 sort of workforce policies, and I know we changed the process that the exec team would approve them, but I think that we said that we'd get highlighted if there's any sort of changes to them. So new policies will come through committees, and so it's just checking on these before we ratify them. Has there been any sort of changes that we need to be aware of, or are they just standard updates just in terms of the regular refresh? Thank you,
Dean. Steve?
Yeah, thanks, Dean. So they are more than just a refresh. They are rewrites of all 3 of those policies, working with staff side to kind of get to an agreed process for each of those 3. And I think, interestingly, you picked up earlier from Charlie's comment around the bullying and harassment that part of our target of actions to make sure that is not something that becomes an issue where we do move away from being average to in the wrong direction. So part of the refresh was around making sure our policy was current. So yes, Dean, they are rewrites, they are changes in that. Obviously they still form the basis of procedural documents for dealing with sickness in short-term, long-term, and trigger points, and in bullying and harassment investigation and the process and setting out how we do that. So I mean, obviously I can share those around from the committee, maybe as a process, pick that up next time to share that as part of the consultation of those policies, because obviously that took place earlier in the year. The job planning one is more procedural, and that's more around just recognising that we've got new IT to support the job planning process, making sure that was built into the procedures so that everyone using it can understand it.
Thanks, Steve. So happy with that in the future. I think it'd just be useful just to say, this was the policy and here's the changes that we've made, just so it enables us to ratify them. Obviously, if they're significant, then circulating them around so people can see them before reading them. But thank you for that.
Thank you, Dean. Can we make sure that we get that in the action log as well? Because obviously, it is approved by the MT, but we're being asked to ratify, and that the policies conform to the required expectation standards. If there's been a rewrite, it's a bit difficult to know how we do that if we're not aware of what the changes are. So I think with that proviso going forward, if we can get that sorted, it would be appreciated. It doesn't need to be massive. It's just what the changes are, I think, in this that's really important. Okay, any other questions? John? Or comments, John?
Thanks, Chair. I think we should just flag the CQC report on Princess Medical, which is in the Chief Execs update. So we always talk about CQC reports whether they're good, bad, or indifferent, and this is obviously, it's not a good read, and I could understand why our colleagues might be anxious throughout the organisation, including at board level, but just as importantly, you know, people who use our services. So lots of learning in that. There's a big comprehensive piece of work making sure that we can pay attention and fix those issues which need to be fixed as a matter of urgency, and that'll come up through EMT and other governance routes. But just also to say, we're looking at some of the learnings from that just to make sure it couldn't happen somewhere else in some of our other services. Now, we have had other CQC inspections in other services in recent times which have come out quite well, but just to flag, you know, that is a report there. It's not a good read. Things are already underway to fix it, and just to acknowledge those challenges in terms of some of the services that we provide.
Thank you, John, for highlighting that within the report. Thanks very much. And it's all gone into the CQC and everything, the action plan, and obviously we'll probably want to know more about how things are progressing down the road. But thank you for that. Anybody else?
Just on that, Chair.
Sorry, Michelle, sorry.
It's a good point to raise, but it will be picked up in the Quality Committee as well and monitored in the Quality Committee. So yeah, we'll get that shown through that route as well.
Thank you, Michelle. Okay, if there are no other comments and questions, can we first of all approve and ratify the policy changes in 1.1 of the Chief Exec's report? Is everyone in agreement? Yeah. Okay. Thank you very much for that. And therefore we receive the Chief Exec's report. Thank you, Michelle, for that. Let's do the publications and highlights report, and then we'll have a little break.
I'll be exceptionally quick then, thanks, Chair. Obviously, the usual report. The only thing I would highlight, Hilary has picked on, is the Ockenden report. A very, very upsetting read for all of us. I'm a midwife by background. It touched me greatly. I'm sure it touched other people. Even though we're not directly responsible for any of the services, there is a lot of learning, as Hilary said, in that. So I'm not going to repeat that. It will be through the various subcommittees and obviously through the Quality Committee. But I'll leave it there. That's the main one to pick out. I'm sure people can ask questions and answer them. But back over to you, Chair.
Thanks very much, Michelle. Any questions? I can't see any. They're there for people to read at their leisure. Thank you very much. Right. Okay, we'll take a little break for, let's just say 10 minutes, a comfort break. Come back at 11:20. And then we'll get on with the rest of the agenda. Thank you very much, everybody. See you soon. Welcome back, everybody. This is the Humber Teaching NHS Foundation Trust board meeting, and we finished at item 10, so we're now on to item 11, performance report. Pete.
Caroline, so this is the usual performance report which takes us to the end of March. You'll recall from last month's board that we discussed that EMT have undertaken a review of the performance report, and there are a number of small amendments which I'll just quickly take us through. So in relation to the well-led review which we discussed earlier, the appendix to the performance report has been relabelled and is now called the performance report, not the integrated board report. And we've removed the 2 finance indicators from the report because we recognise that we already have that information in the finance report, which appears next on the agenda. In addition to that, we have also removed the grey shading, as we brought that in 2 years ago to highlight the start of the pandemic, but it's a 24-month period, so everything would just be grey, so it makes sense just to remove that grey shading from the report. We've included a new chart to show consultant vacancies because they're part of our hard to recruit task and finish group. We've updated the sickness chart to include an indicator, if I can even say it, which highlights sickness excluding COVID, and staff turnover within the report now excludes TUPE transfers in and out of the organisation. So that will mean some of the retrospective data will be different to previous month's report, just a point of clarity there. In terms of the report itself, I'll pull out some key information before we move to questions. So we can see from the Safer Staffing report, which is the performance in February, that sickness was an issue across all of our wards. I think we probably would have expected that based on the sickness in the report last month, and also we highlighted last month some of the information and some of the support we're putting out there, including filling shifts, physio director, etc., to help people back into work. And I guess what I would say is you'll see in the finance report the increased spend on agency, which is part of probably a direct correlation to the level of sickness we've got. What I would say on the Safer Staffing dashboard, as I always do, that our care hours per patient day remains strong. And I think that gives us an assurance on the amount of care we're providing to patients in our units. You'll also see in the performance report that turnover has increased this month and does fall out of normal variation. That's predominantly due to retirements, but you'll see from the commentary in the report, a number of those retirements have already returned to the trust, either under retire and return or by joining the bank. We've included in the front sheet, as we did last month, an update on ambulance waiting times. So that was a snapshot at the time of writing the report, and we are waiting for NHSIE, who are working on producing a report that will be issued to us on a daily basis to enable us to update our operational sit reps and future months boards reports, because I think that's a key area of focus across the ICS. And just finally, I sent a note around the board members because the more eagle-eyed of you will have noticed that incidents were in this month's performance report. We are in the process of updating that, but it just wasn't in the format where we could share it in a public board paper. So under separate cover, we have shared the previous incidents graph, and we are working on incidents adjusted for activity as a statistical process chart, which will appear in next month's report going forward. So I'll pause there for breath, and I will invite questions, or if any of my exec colleagues want to highlight anything.
Thanks very much, Pete. And it was raised actually at Governor Development Session yesterday about being able to see the consultant vacancies, and I was able to say that we were doing something about that. So it's good to have that reported today, that's been done. Thanks very much, Pete. Any questions or comments, please, to Pete? Francis.
I thought I'd take up the Peter Barron challenge. So Safer Staffing dashboard, just a couple of minor questions. Pineview obviously very high on bank when you look at it compared to everybody else, and then on sickness levels as well, which obviously correlates across the two. So I just wondered if there was a bit more we could hear about that. Oldswater again very high on sickness levels, and then Meister and Whitby both very low on some of the mandatory training stuff. So I just wondered if Hilary or Lynn wanted to pick up on those.
I pick up on that, and generally I think it comes back to Pete's point when he presented it. It is literally the sickness levels that's affected a lot of these indicators. This is February data. We were absolutely in the peak then of COVID prevalence being very high. It was really affecting our units, particularly secure services, which has obviously resulted in some of the units using more agency, more bank. it's affected around Statman training staff being available to being actually on duty to be able to attend any of these sessions. Looking at a lot of these indicators now as we're coming through into April, if you think of the clinical supervision one, there's a lot of reds on there as well. I've just got the clinical supervision report for this month, and there's 3, I think, on February. Not even sent the data in. They've all sent the data in now, and some of those are 100%. So we're coming out of it now. The thing that I've taken from all of this, when you pull it across together, is the end and the indicator totals. None of the units are flagging at 5. There's none of them that are red. So given pulling staff from all over to cover in February, when we had such sickness levels, they've managed to keep the wheels on the bus, as it were, and the pulling out of it now is certainly the data that we're getting through. I don't know if Lynn, if you wanted to add anything specifically from your perspective.
No, I think you've covered it all, Hilary, that unfortunately that was the period where our secure service had significant outbreaks, and there was a period of time where every patient bar one had COVID on Pineview, and obviously staff unfortunately were absent at the same while. So as Hilary says, what we are seeing is the recovery of that position taking place now, but unfortunately the staff availability position remains a significant challenge, both in terms of sickness absence, obviously vacancies and turnover, and it is affecting, some of the performance indicators, which I'm sure we'll come to as well. But I agree with Hilary's analysis there.
Which would kind of play back into the staff survey stuff again that we talked about earlier.
Yeah, thank you, Francis. Was there any other comment you wanted to make, Francis?
No, that's it, thanks.
Thank you very much. I've got John, and then I've got Stuart.
So it's partly a presentational just conversation. I think we're all mindful that we're still very much in COVID. And I think when we look back at data, it's very important to remember that we've just been in a pandemic for 2 years. So there is a risk in while we don't need to grey stuff out going forward, there is a risk of removing the grey historically, because I think that could lead to some revisionism and perhaps people forgetting over time the impact of COVID, particularly in the operational setting and people working in operations over the last 2 years. So as Lynn has just related to some data from February, it felt like we were back in the worst prangs of COVID all over again. Yet when you take out the grey, people seem to forget that. So I'm just merely stating that we need to be really, really careful here that we don't fall into the trap of pretending it's all over, nothing to see here anymore in terms of COVID, because that certainly isn't the case when it comes to incidence rates or mortality rates at a national or a regional level.
Thank you, John. Stuart.
Yeah, thanks a lot. This is a question about the rather helpful disaggregation of the vacancy data to include the consultant. So when you look at the graph, it rather alarmingly runs around 30%, around that mark. But I understand from information you've given me, Steve, in advance of today's meeting, that all of those vacancies are covered by temporary agency staff. Is that? Can you confirm that for me?
Yeah, that's the case, Stuart.
Yeah, and I think therefore, Pete, the descriptor, it needs a bit of context around that page, because it said that's the sheer number of vacancies, but actually it's not as though we haven't got capacity in the system through that mechanism. I just think that's helpful to clarify for viewers and observers, if you like.
That's a really helpful comment, Stuart. Are you happy with that, Steve?
I'm happy to update the commentary to reflect that those vacancies have been covered by agency consultants, Caroline, which we'll probably cover in the next paper anyway.
Yeah, thanks very much. Thanks, Stuart. I can't see anybody else indicating. No. Okay, so we'll take away some of those. Oh, sorry, John.
Sorry, it's just in terms of purity of the data. Steve, do you include trust locums in the agency figure? So we just need to be clear, because we do have some people on long-term trust locum contracts, which isn't the same as coming from an agency. So it'd be helpful just to understand that going forward, that we delineate between long-term trust locums and people who come to us on short-term agencies, because they're not quite the same thing.
Yeah, we're very aware of the difference, John, and we report it as those that have got a contract and those that are agency.
Yeah.
Okay. Thanks, John. Thank you. Great. Okay, so is the performance report received by everyone? Yes, I think that's been done. And there's a few little details to sort out for next time's presentation. Thank you for that. We move on then to the finance report. Pete.
Lovely, thank you, Caroline. So this is our year-end finance report, and I guess the most important thing to know from the report is we have hit our operational control total or planning target with the ICS, which was to hit a near as damn it break-even position for the year. You'll see from the report, as we always get to in March, there are a number of technical items that start to come into our financial position, like impairment and valuation of estate. So when we include those, our accounts will be reporting a 5 million deficit for the year, but they're non-cash items. It's purely technical and in the main in relation to the valuation of our estate. You'll see from the report the cash in bank at the end of the year was 30 million, which is still a healthy position. We did see a reduction from last month, and that was predominantly to do with the repayment of the loans, which we've discussed in the Finance Committee before. And it was remiss of me not to mention that when I presented the finance report last month. Our year-end COVID spend was 4.8 million, and our top-up claim was 2.7, which was within our allocation for the year. And our agency spend at month 12 did increase, and at the end of the year it was 8.4 million. Which is quite a significant number for us and an increase on previous years. And probably you'll see from the report, 5 million of that relates to consultant spend. So links to the question Stuart just asked on those vacancies being covered by consultants. We ended the year with strong performance on our better payment practice at 91%. So that's a really good performance considering the context we've operated in. And I guess it's probably important to note that the treatment for the Yorkshire and Humber care record, which we originally intended to bring in as grant income to fund capital, we've been unable to do that, and we discussed this at the Finance Committee, so that doesn't cause us an issue for 21-22, but we are working with the national team with regards to a solution for 22-23's capital programme. And just by means of a quick update, obviously we're in the process of preparing our annual accounts for audit, so our draft accounts have been submitted. They will go to EMT and we'll circulate it under separate cover to members of the audit committee for an early heads up, so that any questions can be discussed and identified. So to summarise, I think great, we've hit our financial control total for the year, and we end the year in a relatively strong position. And I shall stop there and happy to take any questions.
Thanks, Pete. Any questions or comments to Pete? Dean.
Thanks, Peter. I was just looking at the graph on the agency spend as you were talking, and just noticing March 22, just seems to be a high amount there in terms of nursing in that final month, and likewise in terms of clinical support. I don't know if that was just an accounting issue of the year end or whether there was something significant there.
I think the predominant part of that, Dean, is there was a bit of catch up on agency invoices. So we had a bit of we have been using more, not going to deny that, but we had a bit of a catch up on the processing of invoices. So Steve's team and my team kind of gave I'm going to use a concerted effort to clear the backlog of invoices.
Yeah, that makes perfect sense. I know a lot of people do that towards the year end, is just get them all cleared out. Thank you.
Yeah.
Okay, thanks very much. I can't see any other hands, so thank you, Pete. That's received and noted, that report. Thank you very much. I think we have Alison Flack here, who is down at number 19. With the board's permission, I think I should just want to bump Alison up the agenda so we can hear from her and then go back to the rest of the agenda if everyone's happy with that. Yep, great, lovely. So Alison, you're going to present the Speak Up Guardian annual report and talk to us about that. Alison.
Thank you. Thanks, Caroline, and morning, colleagues. So I'll just pick out the highlights from the report because I know colleagues will have seen and read the report. This is the annual Guardians report, and you will know I've been to the board. I come on, I think it's a quarterly basis to update. We are still waiting the annual report from the National Guardians Office. So when we receive that, we will obviously compare our activity and sort of any learning that we need to take from there. We do still have our Speak Up vision and strategy in place, but as you'll see, this is due to be reviewed and refreshed. We have had some conversations with through our meetings with the staff governors, and we think it would be a really good idea to set up a small group and invite staff to be part of that refresh. And we're also getting some support from Sarah Clinch, who's leading on the Trust's refresh strategy, because we obviously want to make sure that it links closely in with that, but that we get staff involved with the refresh. We have, during the year, colleagues will be aware that our Deputy Speak Up Guardian, Alex Saxby, has left the Trust. So we have had a vacancy, which we've advertised on a couple of occasions, but we haven't identified a suitable replacement as yet. In the report further down, there's some more recommendations about looking at the capacity of the Guardians. So I'll talk about that in a moment. We are still having, which is really helpful and shows the board commitment to speak up, meet with Michelle as the executive lead on a regular basis, and up until Peter Barron left, we had quarterly meetings with himself and Caroline, and also, as I said, I've had an opportunity to meet with the staff governors just to talk about the themes from Speak Up and the learning, and just to keep people appraised and to get any further support that we need. All staff, as this was put in last year, but all of the staff attend the level 1, all new staff to Humber attend the level 1 National Guardians Speak Up training, and we've had some really good feedback from new staff about this and how it indicates how seriously the organisation takes speaking up, so we will continue to do that. And only recently, in the last couple of weeks, the National Guardians officers published a new training which is aimed at the executives and senior managers, so I know that staff will be undertaking that. In terms of the numbers of concerns raised over the last 12 months through the Speak Up route, you'll see that we've had 27. This is a slight increase to the number of 24 last year. When you compare us with, because we do submit our data on a quarterly basis through a national portal, and if you compare us with other similar types and size of organisations, we're not a particular outlier. And I think what we also did, Michelle asked me to just have a look at the other trusts, the other provider trusts within our footprint, and again there was no particular issues there around the numbers, and there wasn't anything particular from the recent staff survey that suggested that staff didn't know how to contact us or indeed didn't want to. Just broken it down there. Significant still some of the types of concerns that are raised through us, particularly where it's in relation to a member of staff's own terms and conditions, and I think we've got a really good process now for linking in with our colleagues and signposting staff to HR, and also working more closely with our staff side colleagues, and then the other areas where people have raised their concerns. I think particularly in relation to the team working aspect, there's been a few programmes of organisational development and team building that have been commissioned through Lynn that have helped to address some of the problems. As you know, Speak Up's very much focused on the patient safety and the patient safety elements of concern. That's where we've been focusing, particularly around the waiting list management and some of the concerns that were flagged around induction processes when we were in the midst of COVID. No significant areas of concern, a sort of a range of areas that have been reported, so there isn't a particular hotspot. During the year, there was an area where we did have some concerns, so we did go in and do another review that was requested by Michelle, and through the period, Lynn has commissioned 2 independent investigations to be commissioned, which have been sort of robust and transparent. One is still outstanding, and really importantly to note that no one has formally reported that they've suffered a detriment as a result of speaking up and raising the concerns through this route. Continue to focus on learning from Speaking Up, and there's been kind of system changes as a result of that. And we continue to raise the awareness. The new policy and procedure was approved, which has just been published. The two following additions, which I think are really positive, where we will be contacting staff 3 months after they've raised their concerns, just to follow up and to make sure that they got the support that they need, or there isn't anything else that's concerning them, or the concern is still there. And we do now report any elements of patient safety concerns on Datex, which I think is really positive. We've recently been part of the well-led review where Speak Up was looked at, and there was some actions that were recommended. We're already working through those. I've recently agreed with Michelle that we will have some additional resources, so we will be advertising for some freedom to speak up ambassadors, champions. We're still kind of talking about the title of those and how they'll work with the guardians, and we're going to look at having one of those for each of the division, so that people have got more of a local identified person that they may wish to go to talk to, and it'll give us a bit more capacity and resource within the team. So that's just a quick the headlines from the report, and happy to take any questions. Thank you, Caroline.
Thanks very much, Alison. Are there any questions? There's a few comments in the chat box which you can pick up later, Alison. Just a few typos, I think, in the report. You've promoted Dean to Senior Independent Director.
Sorry, yes, yeah, that's an error.
I don't want a row breaking out amongst the Neds on this. So okay, so let's see who's up first. Let's have a look. Thanks for the report, though. Very good, John.
Thanks, Alison. Alison, you used some data to show that actually there's been a decreasing number of concerns raised over the past 4 years. Can you provide us with any information or context as to why you think that might be? Because it's just a data set. And the second thing is you referenced that actually you have looked at the staff survey and there's no concerns with regard to what's in the staff survey. That data isn't in the report, and I'm just wondering which questions you feel might actually give us the assurance that actually, when you look at the data, we've much to do, but we're doing all right.
Thanks very much, John.
Thank you. Just in terms of the decrease in numbers, because as you say, it's quite significant from the when we look at it over the last 4 years. A couple of things to point out there. I think it's important to note that if sometimes we get more than one person raise a concern about the same thing. So if it's a full team or half a team, that would get classed as the numbers, because that number is people. So we maybe haven't had as many, we've maybe had more individuals contacting us, but not as many bigger teams. I think the second thing is this agenda and this culture has been evolving, and I think, you know, the role of the Guardian wasn't particularly it's developed a lot in the last 4 years, but so we would like to think as the culture and the fact that we've got a freedom to speak up strategy and vision in place, I think staff, it indicates to me that in the main staff feel more comfortable using their managers or their peers. They feel that their concerns are being taken seriously, but also they've now got further support from colleagues in HR as well. And also, as I said, we've compared it to the national sort of statistics as well. Just pause there. John, did you want to make any other comment on that response?
I just think it would be helpful to actually see those statistics in from a benchmarking point of view. From my memory, actually, you might correct me if I'm wrong, wasn't there something about the reorganisation which we did 2 or 3 years ago, quite rightly, sort of creating concerns and stuff, but you wouldn't know that unless that context is put in there. So I'm just kind of thinking how we use the data going forward, really linking it into the staff survey. But when we use historical data, we perhaps just put some of the context in. So it is what it is.
Yeah, no, that's helpful. Thank you, John, for that feedback, and I'll make sure that we do that. In terms of the comment you said about the staff survey, we're still working through that around how comfortable staff feel in reporting concerns and near misses, and if they know who to contact if they've got concerns. So, but in sort of on that initial review of the data, we're not seeing that there's any particular concerns, but as you say, we've still got more to do.
Thank you, Alison. I saw Stuart earlier. Have you put your hand down, Stuart?
You answered the question as I was about to pose it, Alison, about comparison to national data. It's always it's always difficult to know what a kind of a normal level should be, but if the national data exists, it does give you some kind of guidepost. So thanks for that.
Thank you.
Thanks, Stuart. I've got Michelle and I've got Steve.
Yeah, thanks. That's some really good questions. And one of the things around the numbers is one thing that Alison and I constantly talk about, and I know it's picked up in the quarterly conversations with the relevant NED and chair. I think one of the things we can demonstrate, even through COVID, is that we've done a lot of publicity and a lot of promoting the Guardian. So it's not that we're not doing that. And I think that's important to say. It's not that we're not, given our geographical spread, given our number of bases. There is a lot of work that Alison and her small group, I would say team, Alison and her colleague, do in relationship for him to speak up. And I know it's publicised through the exec directors, through me, etc. So there's a lot of that just to reassure the board, and that will continue. And I think maybe we just need a bit of a flavour in the annual report, a bit more about how much we have. It's in there, maybe not necessarily for now, Alison, but maybe for next, how we have tried to communicate it out. Because for me, I would be more concerned if we weren't doing that and the numbers remained quite low. But if we are using every opportunity, and it's not just freedom to speak up week, it's constant. But I do think we do need to just keep that communication going. So I'll just leave it there. Thank you.
Thanks, Michelle. Steve?
Thanks, Caroline. Thanks, Alison. So just couple of things from me, I guess, just expanding on John's theme around the staff survey score. So, I would feel secure raising concerns about unsafe clinical practice has gone from 58% to 80% in 4 years. And I think that's something we should be celebrating. I think that's a direct link into this, and, credit to Hilary and John and colleagues on this in this meeting for helping to promote that. So I think that's something that we should reflect in our annual survey. Likewise, that I feel safe to speak up about things that concern me. Whilst we're marginally below the average, we've certainly gone in the right direction on that. So I think there's a real opportunity to celebrate that. And as John mentioned, there's still work to do, but I think that should go into an annual report. Just on the numbers as well, on the data set, Alison. So you mentioned that there was 27 freedom to speak up in the last 12 months. And you also mentioned that things are signposted into HR. So the things that are signposted into HR, are they included in that 27? And what's the breakdown between of those 27 that were essentially not freedom to speak up under the policy? So they were pushed into, the appropriate trust policy. Have you got the numbers and the breakdown for that?
I haven't got. I haven't got the detailed numbers, and I wouldn't want to just give you. I can give you a kind of a good guesstimate. We do have quite a significant amount of that 27 that we will have signposted in, probably about a quarter, if maybe more. But I'm happy to give you the detail, Steve, outside of this meeting. What I would say is what I've agreed with Michelle is now we're going to start recording them separately, so that we will have the numbers of staff reporting concerns around direct patient safety as one reporting category, and the other one is those that have been signposted to HR, so that we'll be able to look at those numbers better.
Great, thank you. Sorry for my phone going off in the middle of you talking there, if you could hear that.
Sorry, do you want me to repeat anything?
Because I do think it's really important that we understand that breakdown for the board, because actually if a significant number of those 27 are actually things that are personal and we would pick up in the normal grievance, bullying, harassment type procedure, actually how many true freedom to speak up are being raised, and it might be that number then is significantly lower than 27, which when we think about that covers everything around patient safety and some of those other areas. I think that's an important context to try and make. And just finally for me, Alison, I know that when the policy refresh you mentioned in the report about 2 of the changes that were made in the policy refresh, there was also something there about just picking up the national work, which was making it very clear that if something was raised was personal to you, that should be done by the trust procedures, and that wasn't in our previous version of that. Can you just confirm that that is in the new version going forward?
Yes, you mean in terms of it not being appropriate, using the appropriate routes like grievance or the different procedures. Yes, it is.
Brilliant. That was it. Thank you. Thanks a lot.
Thank you, Steve. I can't see any questions. Thank you, Alison, for your reporting today, and look forward to see you at our next quarterly update, stocktake discussion about these important issues. Nice to see you, Alison. Take care. Thanks, you.
Alison. Thank you. Thank you.
Okay, we'll go back onto the agenda, and we are at item number 13. Francis, please.
Thank you, Chair. Peter's covered a lot of this, so I'll keep it relatively straightforward. The key things that came out of our last meeting were from the Insight report. There was an HFMA briefing on scrutinising financial statements, and we've circulated that to everybody on the board so that you all got sight of that. As Pete said, we hit the year-end financial position. I think it would be remiss of me not to compliment the team, because in my 4 years here, they've delivered consistently year after year, and the financial performance has improved year after year. So I think it would be remiss of me not to compliment the executive and the whole team on what they've done. We looked at the BRS for last year, and again, we're one of not too many trusts that have continued with BRS and continue to deliver. And we recommended that perhaps going forward, it would be useful to have a story or a case study come to board about a BRS that's been positive and shown a benefit to everybody, just to show that it's not all about cost cutting. It is about doing things more efficiently and effectively. We received the capital programme for 22-23, which we are happy to recommend to board and will come at a later date. And we agreed the annual effectiveness review, which isn't, as it says here on the board agenda, that will come in May. But those are the key points to call out. Thanks, Chair.
Thanks so much, Francis. Any questions to Francis? No, I can't see anyone. That's received and noted. Thank you very much, Francis. Moving on to item 14. Dean, please.
Yeah, thank you. This is the Workforce and OD Assurance Report. So just to highlight, we receive reports from 3 subcommittees: Health and Wellbeing, Equality, Diversity, Inclusion and Medical Education Committee. In my role as the Health and Wellbeing champion, I attend that Health and Wellbeing committee that's chaired by Lynn. As you can see from there, just a really sort of vibrant subcommittee with lots of enthusiasm and lots of people sort of working well on that. And then in line with the reports in the well-led review, I will be attending meetings of the Equality and Diversity subgroup and the Medical Education Committee. So thank you to John for the invite to that. We got the Workforce Insights report, which gives us a sort of overview of all the different bits of data that we're looking at to sort of triangulate. And I suppose just the one thing to pull out there is just the policy that we've got on the sort of apprenticeship first approach sort of coming through, where we're just trying to get all new vacancies entry level into the organisation into apprenticeships, and we know that's being introduced, so we're just going to see how that's sort of rolling out and sort of keep an eye on that as it moves forward. And then the only other thing I thought to highlight here would just the numbers really. So we do have a look at things like vacancy rates. But one of the things about vacancy rates is sometimes that the vacancies can look stagnant or look like they're increasing because our establishment sorts of increases. So what we've just highlighted on this report is that although we've got still a number of vacancies, the actual net growth in terms of the number of nurses since 2020, registered nurses, is 52 sort of going forward. And then we're just flagging there that, again, just in terms of looking at the data, so things like, receiving the 0 to 19 service changes that sort of baseline again in terms of what you inherit in terms of establishment and vacancies. So just try to look at that in different ways to get some sort of assurance through that. But again, happy to take any questions.
Any questions to Dean? No. Okay, thank you, Dean. That report and the minutes are received and noted. Thank you very much. We move on then to item 15, Stuart, the Collaborative Committee Assurance Report with its shorter title, I think.
Thanks, yes, right. Thanks very much indeed. So this is a report back from the March the 28th meeting. So key issues, as you can see, we continue to keep our eye on the balance of provision inside and outside the patch. We're still noting delayed discharges for, at the time, 8 young people because of limited capacity in the local authority care and community sector. We're definitely keeping our eye on the still emerging position at the Sharon Clinic, which continues to move. On the plus side, safe and wellbeing reviews were complete and have been submitted to the panel at the overall patch level. And work has gone on to review the serious untoward incident standard operating procedures, which is very welcome, and a clinical lead is being advertised to be appointed on a permanent basis. There's another meeting of the committee tomorrow, so there's a degree of time lag in this report, but that's the state of play at the end of March. Thank you.
Thank you very much, Stuart. Are there any comments or questions to Stuart on that report? No, okay, thank you. That's received and noted. We move on then to item 16. Lynn, you're going to take us through the Emergency Preparedness, Resilience and Response Annual Report, Assurance Report. Thank you, Lynn.
Thank you, Caroline. Yes, well, I hope the report is fairly self-explanatory, actually, and obviously sets out the key issues. Again, the report is set in the context, as we've already discussed today, of within the last year's impact of the pandemic. So I think overall the report is suggesting that despite those pressures of actually continuing to live with the impacts of that, the EPRR requirements have still been met. The report contains the summary in relation to our self-assessment against the core standard, which the board has seen here previously, and the work that we're undertaking to take those forwards. We do have a plan in place for next year. It's always important that we test our emergency planning and resilience arrangements, including our business continuity plans. So we do that through some wider system test processes, and we do that internally within the trust as well. Training is core to ensure that our staff, senior managers, are skilled to manage EPRR processes within the requirements. So again, there's further plans for that to take place, as there has been over the last year. Mike Smith is our non-exec director with lead responsibility for emergency planning. I know Mike has received this report as well, but I'm very happy to take questions, but conscious Mike might have some comments too.
Thank you, Lynn. Mike, did you want to add anything?
Yes, yeah. I've been kept in the loop by Lynn and Lisa James, for which I'm grateful. The planning continues. It's a never-ending one. There's a couple of queries though, and that's that at the last meeting we talked about NED champions, EPRR, even though I may continue to be the liaison, is a whole board responsibility, and needs to go to be assigned to a committee. I'm guessing that will be audit. But the last minutes just said that it would be discussed by chairs. I don't know if Stuart knows that. The other one is that there's a reference to a desktop planning exercise in April 22. Well, we're nearly at the end of April 22, so I just wondered whether that was when it was being planned or when it was being implemented.
Thanks, Mike. Lynn?
Just on the first point, I don't know if Michelle wants to pick that up in terms of which committee this relates to, but it would typically be audit committee in my view, if that's helpful. On the second one, Mike, there was a short delay. Unfortunately, due to the pressures that we've talked about, but it is in planning now. So it is expected to happen in June at the moment.
Thank you. I acted as observer at the last desktop planning. If there is a role for me, I quite enjoyed that, and it's part of my NED role. Thank you.
Thanks very much, Mike. Any other questions or comments to Lynn? No, thank you very much, Lynn. That's received and noted. You're still on, Lynn. Recovery Strategic Framework progress update, please.
Yes, thank you. So again, hopefully this report is very self-explanatory. Those of you that were board members around this time last year will recall that I brought our updated strategic framework around our recovery work that built on the previous strategy that had been in place. This is a update we are planning at the end of the year, which will be end of May, to have a full evaluation of the work that was set out in that strategic framework. I think overall, Caroline, I hope the report demonstrates that despite the pressures across services over the last year, we have made progress in what I consider to be a really important area for us, particularly around our mental health services. But increasingly, we're considering how recovery approaches and principles apply to our services outside of mental health overall. So I think it's been a good year's work. We heard from the peer support workers at our last board meeting, embedding and meaningful engagement with people with lived experience is at the heart of a recovery framework. And again, I would connect those two updates together. I think we've made very good progress with the development and support of the peer support worker roles, plans to expand that further as well. This was a very co-produced strategic framework with our wider stakeholders, particularly with our service users. And as you can see, the work has been implemented in a co-produced way as well, with staff working very closely with our service users and carers, those people with lived experience, through every element of it. So happy to pick up any questions, but I'm happy to share the fuller evaluation at the year end as well that's in train at the moment.
Thanks very much, Lynn. It was very good, the peer support workers presentation at the last board. It was really interesting to hear what they were doing. Michelle.
Yeah, thanks, Jane. Really good to see this. And yes, I think it'd be great to see that at the year end, the data. And I think it's just a commendable, really. I think, as Lynn alluded to, that throughout this, we've continued to do this work, which is really important, because we all know that we've talked about the recovery phase of COVID, and as we get into an endemic situation. So I think it's really important this work has continued, and we keep that thread going through the board meetings that we built on the peer support workers last time, but just really positive work, and really pleased to see it. So thank you for that, and the team. So look forward to seeing how it progresses further.
Thanks very much, Steve. Sorry, Steve.
Yeah, thanks, Lynn. Just on the recovery college aspect that's in there, that's also accessible to staff, isn't it?
It is.
So I think just wonder whether it's worth just making that aware that we've actually rolled that out to our staff as well as part of our offer. So it might be worth just highlighting that, because I think that's a real positive. Yeah.
It's available not only to our staff, but through some short-term monies this last year as well. It's been made available to our wider staff in our ICS as well, which is great. I will thank you for raising the Recovery College. Was adapted very quickly, for those of you that remember, because in the main, prior to COVID, it was a face-to-face offer in sort of community venues, and we have built and developed, again with support from our IT colleagues, I have to say, which has been invaluable, a virtual platform for that. Increasingly, obviously, our offer is going to be going forward in that blended approach. So some of it will revert to face-to-face, but some of it obviously will remain on the digital platform, specifically because it's really increased its accessibility to our patients, to our service users, and indeed our staff. So,
okay, thanks. Thank you very much. And I know there's been some really good developments on the PACE side, with some different launches of different support training and what have you to support their greater involvement in this, link to sort of every member counts as well, which I think plays into this very, very positively. Okay.
Absolutely agree, Captain. The pace work and the recovery work really work hand in glove together. You can't do one without the other. So an important relationship there.
Brilliant. Thanks very much, Lynn, and thanks to everybody behind this work. That is received and noted. Thank you very much. We move on to item 18, Michelle. Report on the use of the trust seal, please.
Yeah, thank you. Apologies, you should have the document that relates to this year now in your pack, which is April 21 to March 22. It's a usual report. Every time we do a sealing, we have to obviously rightly report it, and then annually bring it here over that year, how many times we've used a trust seal. So it's just here for noting, Chair.
Thank you very much. Is that noted? Yes. Fine, everybody's got that. Sorry, Pete.
Just one for the minutes, Caroline. So the land transfer, we did seal the document, so it's right to record it, but we didn't complete the sale. So that sealed document is in the archive of our solicitors. I think it's just for the minutes to capture that.
Okay, thanks very much for that clarification, Pete. Thank you. Okay, moving on then. We've had Alison, we took her a bit earlier on freedom to speak up. Items for escalation. Any items for escalation? No. Any other business? No. Okay. So thank you very much. That's the end of the public board meeting. Thank you to those who've watched, or maybe you're watching at a later date, and you're welcome too. We're going to close now, and my colleagues will join us for our private section of the board meeting. Thank you very much, everybody.